welcome who didn't attend the welcoming speech before. This is the Saudi German Hospital Riyadh branch. As per our webinar, every day we have 2 sessions. Today we have 2 sessions covering nephrology and miscellaneous items, including hematology and gastroenterology. Every day we have in each session 4 to 5 presentations. Each presentation is 20 to 25 minutes, and then we have question and answer. These questions and answers, you will find it in the icon down with Q&A. You may type your question, and from my side, I will send these questions to the professor or the presenter to answer it, whether after each presentation or collectively at the end of the session. Also, you will receive an email with evaluation form. For the CME hours, it will be accredited for those who had the full registration with payment, and it will be by the end of the final day, which is today. And for any inquiries, please contact Mr. Tamer Ahmed, our organizer, and this is his phone number, and also you'll find WhatsApp on same number. Okay, thank you. And as per our schedule, we are delighted to have Dr. Sami Riyadh from Mayo Clinic. Welcome, Dr. Sami. Dr. Sami is transplant nephrologist and the pancreas transplant specialist. He completed his training in nephrology and transplantation at University of Minnesota, where he learned his master's degree in clinical research. And also he had several leadership roles, including transplant fellowship training director and pancreas transplant medical directorship. Dr. Riyadh's research interests include tailoring immune suppression in older transplant recipients and the machine learning in large transplant registries. Today, Dr. Riyadh will share his experience with us regarding the post-kidney transplant rejection. Thanks for joining us, Dr. Riyadh.
Thank you so much for the kind introduction, Dr. El-Ghitani, and I'm very delighted to be here today with you and with the audience.
Thanks, Dr. Sami. You may give a brief introduction about about yourself and the presentation, and start sharing your presentation through sharing a screen.
All right, so let's start with sharing the screen. So I'm Sami Riyadh, currently a transplant nephrologist and senior associate consultant at the Mayo Clinic, Rochester. And I would like to thank the organizing committee for the invitation. And I'm excited to talk to you today about acute and chronic rejection after kidney transplantation. I have no financial disclosures, but some of the medications that we're going to be talking about in transplant rejections are off-label use. So starting with rejection diagnosis. So there have been many efforts over the years to kind of quantify rejection after kidney transplantation, and the efforts were joined by the histologist or pathologist and surgeons and nephrologists who formed the BANF committee to come up with a nomenclature to quantify rejection and decipher what kind of rejections, and deep dive and find out the mechanisms that are involved with the rejection. So here on the right of the screen is the cartoon that I usually draw when I talk about rejection. So I was able to get this on the slide. So what you're seeing, this is a schematic representation of what you see on kidney biopsy. On these are the tubules, these are vessels, and this is the interstitium. And to the left of the screen, this is the glomerulus. These are the tiny spaces between capillaries, peritubular capillaries. This segment signifies the microvasculature of the kidney with glomeruli. We're going to refer to that by G score. And the peritubular capillaries, we refer to that by PTC, and that also gets scored from 0 to 3. In the basement membrane, there's other stains that we use to delineate the complement to split product, the C4D stain, and this also gets scored 0 to 3. On the right of the screen, you see the tubules. So we usually refer to that as the T, and is scored from 0 to 3 based on the degree of inflammation, and V is the vessels, also is scored on scale from 0 to 3, and I is the interstitium. So Banff criteria categorize rejection into cellular rejection, and the grades of that are borderline, 1A and 1B, and we're going to dive into that in a minute, 2A and 2B, and 3 antibody-mediated rejection, which signify or evident by the microvascular injury, and plus or minus the C4D staining. Chronic rejection, all these scores can be acute or chronic. With chronic, you'll find a C attached to the compartment, and that reflects the chronicity score. There had been evolving non-invasive rejection diagnosis tools, but these are, again, evolving. I'm referring to the donor-derived cell-free DNA and the peripheral blood gene profile. So they are still in the evolution space. Nothing like a biopsy. The biopsy is, as of now, the gold standard, whereby that even if any of these tests that newly developed are abnormal, is still the ability to distinguish which kind of rejection, cellular or antibody, is still fuzzy. So to the right of the screen, this is the Banff criteria, started in the 90s, and every year there had been iteration. So that is a good reference if you, the audience, want to read more or get the details in this publication, will be helpful. So with T-cell mediated rejection, the borderline typically refers to minimal inflammation in the interstitial space. So it's I score with any T score, and or high inflammation in the interstitial space, any grade, but the tubular compartment is barely inflamed at T1. The treatment is debatable and varies by center. Some of the centers are steroid-free, so they use induction maintenance without steroids. So if they run into borderline rejection, oftentimes these centers would rely on treating that rejection. The rejection typically consists of pulse steroids, IV for 3 days, followed by brief oral taper. Many centers with borderline rejection, they don't change the scheme of steroid-free maintenance, and they elect to intensify the immune suppression afterwards. Some centers who feel that who have their patients on triple therapy often elect to intensify the maintenance regimen, assure adherence, the patient is taking their medications, and some elect to treat as well, despite the 3 drugs therapy, and the clinical context is important in this case. Moving on from borderline to Banff 1A and 1B. So essentially, grade 1 rejection is in the tubular space, or tubulo-interstitial space with spared vascular space. So the score has no V, so it's only I and T. 1A is up to T2 and 1B is up to T3, which signifies more severe tubular inflammation. That treatment there is also pulse steroid for 3 days, followed by taper, followed by immune suppression intensification. Now, one caveat is biopsy adequacy. So in order for the biopsy to be adequate, you have to have certain number of vessels, and that's 2 or more, and 8 glomeruli. So having only 2 vessels on the biopsy, sometimes in situations with 1B rejection, if you miss the vessel that has inflammation, you may run into steroid resistance with 1B, whereby if the creatinine is not coming down with 1B rejection, oftentimes clinicians would escalate to the next step, which is deploying a depletional agent to help contain the rejection. So with BAMF 1A and 1B, they're always or many centers would rely on a closure biopsy after the treatment of the rejection to ensure the inflammation had been contained, and to assess if additional immune therapies or immune suppression indication is evident on the biopsy. Starting with BAMF 1A or 1B, if the person is on steroid-free maintenance, they are often switched to steroid maintenance, and after the rejection, they would be on triple drug therapy. Moving on to BAMF 2A, that means the inflammation is spilled over to the vascular space. And we have 1A, 1B. 1A is the milder form than 1B. They both require depletional agent, and the most commonly used agent is rapid anti-thymocyte globulin in a greater dose or cumulative dose of 6 to 10 milligram per kilogram, and it's typically divided in 4 to 6 doses. It's the typical dosing is 1.5 milligram per kilogram per dose, and some centers can use up to 2 milligram per kilogram per dose, but the cumulative dose usually remains under 10 milligram per kilogram. Alternative to rapid anti-thymocyte globulin, the horse sera AdGem, similar compound, but not as efficacious in terms of the kidney transplant realm. It may be more efficacious in bone marrow transplant realm. Almatuzumab, anti-CD52 molecule that or agent that is can be used as salvage therapy when the person cannot get thymoglobulin for some reason, or they are allergic, or they have failed treatment with thymoglobulin. Following the treatment with depletional agent, the immune suppression is intensified 6 to 8 or at times 8 to 10 for a few months, and then it gets tapered down to 6 to 8 and 4 to 6, and patients go on prednisone if they were not on prednisone. There's a closure biopsy to assess the response to treatment and if any additional treatments are needed. Other measures for treating rejection depends on the clinical context. If the person is not on tacrolimus, CellCept, which are the backbone of the current day transplant and account for 90% of maintenance immune suppression, at least in the United States, then if the person is not on TAC MMF-based regimen, like for instance, if they are on cyclosporin, they are oftentimes switched to tacrolimus. If they are on belatacept, sometimes they are switched to tacrolimus, or if the reason that they are on belatacept that they did not tolerate a CNI, so usually they would be on a regimen with belatacept, CellCept, and prednisone. Some center add a small dose ImmTOR on top of that under certain circumstances. So what is the evidence behind treating rejection? The first person who treated rejection was, as the history tells us, is Dr. Tom Starzl, and that's back in the 60s. It was very detrimental field in the beginning, where if rejection happened, the kidney is often lost, and it was very hard to maintain kidney beyond the year until rejection was surmounted with large doses and prolonged courses of steroids back then. But this here, I shared some historic evidence where steroids were compared oral versus IV. The current practice relies on IV. But if we believe the data from 1978, oral doses also have been employed and worked, and some anecdotal experience with that in our current day exists. But the baseline is steroids is a go-to for rejection, and especially in the cellular realm in the milder form. Thymoglobulin. The depletional agent are kind of one of the things that developed and propelled transplant forward back in the days, with paucity of options for immune suppression maintenance, and they were found to be durable and effective solutions for acute cellular rejection early on. And that's where this publication here compared Thymo versus Adgam and shed light on some of the dosing and the duration. So these are for some light reading after the session. Amatuzumab, this is the anecdotal experience with amatuzumab. It's not very common to use. Again, rapid anti-thymocyte globulin for BANF 2A or above is the mainstay of treatment. Now, a reminder that every time you use depletional induction or depletional agents to treat rejection, we are cognizant of using PJP prophylaxis with either Bactrim or Dapsone or pentamidine inhalation or atovaquone, although this is the least favorite option for patients and cost-wise, and to deploy some CMV prophylaxis, as CMV can reactivate with depletional agents. So these are, and some centers can use antifungal, but it's not typical, only for treating rejection in kidney transplant recipients. So that concludes the cellular rejection. Now we're going to move into the antibody-mediated rejection. And in diagnosing antibody-mediated rejection, the BANF the BANF scheme relies on the following: dysfunction that is associated with evidence of microvascular injury, either in both glomerular and peritubular capillary space. And as we remember, the score goes from 0 to 3. These two spaces have to add up to 2 or greater. With that, in addition to the microvascular injury, is the complement activation and the presence of C4D. However, over the years, and where the BANF criteria reiterated and changed and looked at the progress, C4D is not a must criterion. There is a big entity that is C4D negative ABMR. And in addition to these two bullet items, the presence of circulating donor-specific antibodies, and that is a blood test. And the donor-specific antibodies usually refer to HLA, but they can be against other non-HLA antigens. Now, while the cellular rejection appeared to be compartmentalized and categorized in a nice way, ABMR is a spectrum. Now you have, and it has phenotypes, and the when it happens is also very important, early versus late. And early is debatable. Is it early less than 30 days, more than a year? But it's most of the literature is zones in or hones in the first period post-transplant or in the first year. So there's that phenotype with acute ABMR that happens early on within the first hospitalization or shortly after transplantation that can present as ATN picture with with a decline in urine output, and the biopsy would show ATN, microvascular inflammation, and C4D positivity. Sometimes it's the only feature on the biopsy is ATN and C4D positivity, and the urine output is very low. That is very typical of ABMR and something that we always look for. Luckily, with the advancement in tissue typing and cross-matching, we rarely see it, but it's a very known entity. There's the active smoldering ABMR that can be subclinical, picked on per protocol biopsy. It can show some features of capillaritis plus or minus C4D with or without circulating DSA. Chronic active ABMR, this is an entity that is very difficult to treat, and this can be picked on a biopsy. It can be a sequelae of late ABMR where there's some activity and there are chronic changes associated as evident by transplant glomerulopathy or onion skinning of the peritubular capillaries. And the chronic inactive ABMR is kind of, the features are more of scarring and chronicity and less of the active inflammation. So in talking about potential therapies in ABMR, this cartoon represent the potential targets. So antigen presenting cells and T cells can be pulsed with steroid and in some instance thymoglobulin. B cell, there's B cell therapies like retox plasma cell therapies that came and go as it was not proven efficacious, but it has some applications in some anecdotal space. IVIG and plasmapheresis by far since the beginning have been the mainstay of treating early antibody-mediated rejection by removing antibodies, giving the IVIG plus or minus retox. So the typical treatment for early antibody-mediated rejection or early diagnosis. So typically in the early part after transplantation, and or if there is a clinical scenario where the clinician feels that this is early antibody-mediated process and embarks on treating it. So plasmapheresis, 1 to 1.5 volume, it goes to 5 to 6 treatments. Usually the plasma exchange is followed by IVIG dosing, and that varies. Some centers would use 0.2, some centers use 0.5, and usually many would agree closing with the larger dose of IVIG up to 1 gram per kilogram. Solid medrol in doses of 100 to 500 up to 3 times with the treatment are used frequently, and plus or minus retox. Alternative treatment emerging is the eculizumab, the C5a inhibitor. Immune suppression intensification is part of the therapy, and assuring that the person is adherent to their medication regimen is key for in any rejection. And closure biopsy, like the story from the cellular rejection, to see where the inflammation stands after treatment and if the person has responded, in addition to regaining their allograft function. We always like to see what's going on a tissue level. So this is some of the evidence behind the retox, and it waxes and wanes early on after transplantation. It may has a role. Some people feel like it's in late stages can be used. the mainstay remains for the plasmapheresis IVIG plus or minus retox. Pertuzumab had been proposed time and again, and there's some anecdote here there, but there was that small but yet randomized trial where they compared the role of pertuzumab in 44 patients with late ABMR, and the conclusion was pertuzumab did not alter outcomes in late antibody-mediated rejection. Eculizumab, the Mayo Clinic in Rochester had very good experience with eculizumab and incorporated it in the clinical practice. And this publication is available for your review. Eculizumab can be deployed and used early on when ABMR is suspected, or if the transplant crossed an HLA or preformed DSA, and there's an element of memory response that is the patient faces early post-transplantation, then eculizumab can be deployed under these circumstances. Treatment is immense and continued for 30 days or so, or maximum 10 doses in cases of delayed graft function. And with eculizumab, we prophylax additionally for encapsulated organisms. So meningococcal vaccine needs to be arranged, and or if the person is not vaccinated, then they are put on prophylaxis early on and they get vaccinated with it. So this publication that came out from the TTS work group on antibody-mediated rejection and summarizes the grade of evidence and the histology and the proposed treatment, and essentially covered the things that we talked about in the last 5 minutes here. Now, just to touch base on emerging therapies for chronic antibody-mediated rejection, which is an entity that is very hard to treat, is IL-6. IL-6 is interleukin-6, and it's implicated with the initiation of acute phase inflammation, stimulates B cells to increase antibody production, increase plasmablast, decrease Treg function. But if we block that, then many of these mechanisms will be impaired, and therefore, hopefully, the antibody-mediated rejection process slows down. In this early publication on the role of IL-6 in antibody-mediated rejection, the chronic portion of antibody-mediated rejection, in preventing the sequelae, the group here, or the authors of this publication, have randomized 10 subjects with DSA positive ABMR that took place over a year from transplantation, but still had preserved allograft function at estimated GFR greater than 30 ml per minute to either IL-6 blockade in the first 3 months or none. And then after 9 months, everyone in the study went on the medicine. And in this curve, it shows that the trajectory of those who went on IL-6 blockade was better than those who did not. And then after the introduction of the IL-6 blockade in the placebo arm, you see the line leveled off quickly compared to the early part of the study when they were not on that. So that more to come on that. These are 10 and 10, and it showed difference. So we will hear about that in the future. Other forms of rejection, mixed rejection, and decision-making factors for that is timing, early versus late, chronicity, how much tissue is there to salvage, and determining the patient's adherence. Now, rejection treatment is very, very hard when when patients are not taking their medications, any way you slice it. So adherence is a big determinant of outcomes, and sometimes it's the point of no return when you see mixed rejection. But oftentimes, for the benefit of the doubt, at least steroids are deployed. If the inflammation is severe, and the tissue shows significant chronic changes, we still deploy steroids for to avoid any other additional complication related to the rejection and the inflammation that comes with that rejection process, even though it may not be salvaging much. So the treatment is combination of what we use for T-cell mediated rejection, antibody mediated rejection. RATG is often deployed early on when there is much tissue to salvage, but if there isn't much to salvage, then thymo is not used. Intensification of the immune suppression as tolerated. So in summary, acute cellular rejection can be mild or moderate, and as long as it's in the tubular interstitial space, steroids are the treatment with intensification of the immune suppression. If the cellular rejection is severe and entailed the vascular component, we usually deploy a depleting agent, and that is thymoglobulin or RATG. In terms of acute antibody-mediated rejection, it's Plex IVIG plus steroids, optional B-cell agent. Complement blockade early on can be helpful, in plus or minus the Plex can be used by itself, can be used in the context of Plex and IVIG. IL-6 blockade for chronic antibody-mediated rejection is an option. Or emerging option mixed rejection, like we touched based on, and chronic rejection, no proven therapies, but immune suppression intensification and maintenance adherence with medication is key. With this, I conclude the talk about rejection, and I thank you so much for your attention.
Thank you, Dr. Sami. It was a very nice, comprehensive presentation. You took us from the scratch, from beginner levels to expert levels in transplant rejection. And we have no questions right now. And I hope you can join us next year in our internal medicine webinar. Thank you.
It will be my pleasure. Absolutely. All right. Thank you so much.
You're welcome. And now we have Dr. Khalid Al-Muasim.
السلام عليكم.
وعليكم السلام دكتور خالد، أخبار حضرتك إيه؟ تمام؟
الله يعطيك العافية. حياك الله دكتور أحمد.
Dr. Khalid Al-Muasim started with us 6 years ago, and this is the 7th one. Dr. Khalid is nephrology consultant and the associate professor in Al Faisal University. He's the head of nephrology department in King Fahd Medical City. Dr. Khalid will talk to us today about his experience in contrast-induced nephropathy. I think, Dr. Khalid, you had published a poster or something like this in ASN regarding CIN, or?
Yes, and I will share this with you today, inshallah.
Yes, I remember this poster. I saw on your Twitter, I think before, maybe 2 years back, right?
Yes, true.
Yes. And also, we will have a later presentation about vasculitis. Thanks, Dr. Khalid, for joining us. You gave us this honor, and we are very happy that you are sharing this experience with us. Thank you.
Thank you, Dr. Ahmed, for your kind introduction, and thank you for the invitation. It's my pleasure to be here with you today. And here's my disclosure. I have no conflict of interest. And this is the outlines of my presentation. So I'll talk about definition, talk about burden of disease and pathophysiology and risk factors. Then we'll come across some preventive measures. So if we look at the definition, contrast-induced acute kidney injury, actually, we used to call it contrast-induced nephropathy. And this name has changed recently. And it's acute kidney injury actually, because it's after exposure to iodinated contrast media in a variety of diagnostic and interventional procedure, including catheter-based angiography and intervention. And it's not uncommon to be seen after a procedure, especially if the patient has risk factor. So if we have this AKI, does it have any impact or any consequences? And in some literature, they consider this kidney injuries as syndrome, and it's associated with considerable morbidity and mortality and high cost. Just if we look at the literature, we can find in different papers and studies they use different definitions for the acute kidney injury associated with this contrast. And we have the Aiken, we have the KDIGO definition, and many others. I just want to show you here. One of them is the acute kidney injury. And you can see it's up to 7 days on the left side. Sorry, I'll just need to use the laser pointer. So here, just you can see here, it's up to 7 days. We can call it an injury. And these are the criteria to define it as an acute injury. And if it goes beyond 7 days, it becomes acute kidney disease. And it might require dialysis or not, and regardless of if we have different levels of creatinine, then we call it up to 90 days acute kidney disease. And if it goes beyond 90 days, we call it chronic kidney disease. And as you know, we have different 5 stages for chronic kidney disease. If we look here at the burden of the disease, and we can find many studies in the literature, and they looked at the burden and the prevalence of the acute kidney injury according to the type of procedure. And if we look at the coronary angio intervention, we can just, I'm showing some of these papers here. The NEFRIC trial, they include 129 patients, and you can see the prevalence of acute, or the incidence of the acute kidney disease around 15%. And in this trial, they include almost like 300 patients, around 14%. And this trial, they have a larger number of patients, around 600 patients. The prevalence or the incidence was 2.7%. So you can see there is a risk of, or there's incidence of acute kidney injury, but it is variable from one study to another. And this might be related to the type of contrast, type of risk, or the risk factors that the patient have. If we look at another type of intervention, which is percutaneous coronary intervention. So we can see here in this diagram here, we can see that the one in blue, this is the contrast-induced acute kidney injury. And you can see across different studies, we have variable percentage. It can go up to 20%, and it can go as low as 3.2%. How about the acute kidney injury requiring dialysis? We can see in some studies, some patients, they required dialysis after kidney, contrast, and if they have complex PCI, they can have a higher risk of acute kidney injury requiring dialysis. And even non-requiring dialysis, it is higher in some studies. If we look at also the type of the patient, and if they are ICU or non-ICU patient, if they are critically ill, we can see here, for example, non-ICU hospitalized patient, the incidence is in 1 in 5 in this study, and percentage of people is less than 10% who required renal replacement therapy, but the mortality was 10 to 20%. While critically ill patient, they divide them adult and pediatric, and you can see here the risk is going up, and the renal replacement therapy requirement is higher. And if we look patient undergoing cardiac surgery, it's almost similar to non-ICU patient, but they required less renal replacement therapy, and the mortality was up to 10%. If we look at patients who have sepsis, we can see that the prevalence is variable, but the renal replacement therapy is higher, and the mortality even higher. So we can see it depends on the type of the procedure, and it depends on what kind of of morbidity the patient have, the risk of acute kidney injury is variable and can go up. This is just some summaries of some of the studies. Cole and his colleagues reported that the 2-year survival of patients who suffered acute kidney injury after contrast requiring dialysis after BCI was only 18%. And you can see requiring this is 80% after contrast is considered to be high. And there is another decimal figures were reported by Groberg and colleagues who observed a 1-year mortality of 54% in subjects who developed this acute kidney injury requiring dialysis after PCI. So it's not about getting dialysis, but also the dialysis will increase the mortality itself. And at 1-year follow-up, 70%, 75% of the patients who required in-hospital dialysis and were discharged on permanent dialysis program were still on dialysis. So you can develop acute kidney injury, you can get beyond dialysis. So it can be permanent dialysis, or it can increase also the mortality. Another large cohort study, and then they have and the registry, and they looked at the acute kidney injury, and it was associated with post-discharge risk of death, myocardial infarction, and for each outcome, the highest incidence was within 30 days, although the survival curve continued to separate throughout 1-year follow-up. And this is from a large registry. So what are the risk factors for developing acute kidney injury post-contrast? We have patient-associated risk factors, which include pre-existing renal insufficiency, if patient have diabetic nephropathy, elderly above 70 years of old, if the procedure is like having hypoperfusion, like dehydration, hypotension, bleeding, if someone have congestive heart failure, hypertension, anemia, metabolic syndrome, hyperuricemia. Of course, if you are using nephrotoxic drugs, will increase the risk. And there's some factors related to the procedure, like excessive use of iodine agent, high osmolality or viscosity iodine agent, repeated exposure of contrast within 72 hours, and imaging technique like angio exerted an increased risk of contrast-induced injury compared to the CT. And embolization during femoral catheterization also increased the risk of the AKI. Here's the contrast type, and if we look here, so we have the isoosmolality, which is close to the blood, and it's around 290 here, and this is the iodine concentration, and you can see here the viscosity at this part. And we have the low osmolality and high osmolality contrast. So which one have higher risk? If you look here, this is the nephrotoxic contrast media. If you see the green one, the isoosmolar, which is close to the blood, it's non-anionic, and it's considered to have mild risk of nephrotoxicity. So it's not 100% safe, but it has the lower risk. If you look at the low osmolarity, and we have different type of low osmolar iodine contrast, we can see here that they are considered moderate nephrotoxic. And if you look here at the high osmolality agent, they are considered to have the severe toxicity among the others. If you look here, if we give the contrast, then the contrast, it can exert immediate cytotoxicity, and this is related to the oxidative stress leading to renal vasoconstriction, and it increase adenosine, endothelin, and prostaglandins, and decrease the nitric oxide and the other prostaglandins. And this will lead to medullary hypoxia, and this can cause tubular damage. At the end, we have the nephropathy or acute kidney injury. Also, the renal vasoconstriction will decrease renal blood flow and will lead to the acute kidney injury. Also, we can have increased intracellular calcium. And this by itself, it can be direct tubular cytotoxicity leading to apoptosis and AKI again. And the contrast media osmolarity itself, it can increase the tubular fluid osmolarity, lead to increased intratubular pressure and decrease urine flow rate, and this will drop the GFR. And also it can increase the blood osmolarity and it can lead to medullary hypoxia. So it's a complex process actually. And through the different pathways, we can see that this will lead to acute kidney injury. Now, you see, this is a busy slide, and all these are multiple preventive measures trying to minimize the risk of mortality and morbidity that we talked about. So our aim is that we want to attenuate the direct cytotoxicity of the contrast medium, and we have different ways of doing it. So we can use the proper use of contrast medium. So it's better to use the isoosmolar. It's the selection of the optimal contrast medium type, as I mentioned. And we try to use other alternative to contrast. For example, if we can use CO2 angiography or dextran-based OCT. Also reduction of the contrast volume, the minimum as we can. Avoiding the angiography if possible, we can use IVUS or MRA. We can give a personalized hydration, and this can be CV guided or left ventricle guided hydration or other types, or we can use the renal guard system. Also, we can improve the contrast-induced renal ischemia by giving some agents like vasodilators. We can use also calcium channel blockers like amlodipine can show some benefit. Prostaglandin, oliprost show beneficial effect, some antioxidant. And just I would like to mention that the use of routine administration of N-acetyl cysteine and sodium bicarbonate are not recommended, and I'll show you the evidence down the road. And high dose statins are recommended. All these are tried preventive measures, but let's see the evidence behind each one of them. This is an approach from Mehran, and he's well known in this field of acute kidney injury post-contrast. And you have to assess the patient, look at the risk factors before you give the contrast. And we have the Mehran risk assessment score. It's available as an app, so you can look it up. So we will use low osmolarity or isoosmolarity contrast medium, and we will minimize the volume if the patient is high risk. And we will suspend the nephrotoxic medication, and we can administer intravenous isotonic sodium chloride. And we will perform assessment follow-up of the kidney function. If patient is low risk to start with, we can use the low or isoosmolar contrast medium, and we consider suspending the nephrotoxic medication if indicated. We have different pharmacoagent and the treatment to try it for prevention. And the famous one is the normal saline that all of us are familiar with. And these are just, in this table is a summary of multiple trials where they used normal saline or normal saline for prevention. And all of these are RCT, either prospective trials or multi-center trials even, and they use this diagnosis of acute kidney injury for the patient, and they used a different method in each trial to assess or guide the hydration. Some of them they use the CVV guided hydration, some of them they use the left ventricular, maybe renal guard system, and others. And almost all these trials showed that they have positive outcome regarding using the normal saline and prevention of contrast-induced nephropathy. So now, always we have this question, the literature, which one is better, the normal saline or the sodium bicarb for prevention? And we have this trial, and this is a summary of multiple trials actually. And if you look here at this summary here in this table, that there's no difference between using sodium bicarb, and it was not superior to normal saline for prevention. And in some of these trials, they used even an acetaminophen. So the conclusion from this meta-analysis that the use of sodium bicarb is not superior to the use of normal saline alone, or with even the use of an acetaminophen to prevent the contrast-induced nephropathy or acute kidney injury, regardless of the risk factor that they have. So normal saline by itself is enough. How about the other pharmaco agent for prevention? So we can see here a big list of medication that's being used in the literature, starting from statins, allopurinol, ascorbic acid, bicarb, citrate, and it's a big list actually. And almost all of them, they did not show strong evidence, maybe except for statin. And you can see here in this statin, how does it work? Or the HMG CoA reductase inhibitor, we have a different mechanism. So the mechanism of action of these, that it increased the nitric oxide bioavailability. It works as an antioxidant, anti-apoptotic, antithrombotic, anti-inflammatory. So it has different mechanism, and it has effect as vasodilator, reduce the peripheral glomerular filtration, reduce fibrosis. So it has many effects in the kidney. And also it works for reduction of cholesterol biosynthesis and lipid production. And this is additional atheroprotective effect. But of course, this is not as fast as the other mechanism. And if you look here, this is a summary of multiple trials that support the use of statins and prevention. And they use a statin either as high dose or regular dose in different cardiology study, and they use PCI or angiography, and the reference strategy was normal saline hydration. And we can see here that it has some positive effect on some of these trials to minimize the risk of contrast. So what is the confirmed evidence of a statin? It's dose dependent. So you have to use high dose. It has rapid action. It is independent of the LDL reduction. It is non-interference with routine hydration, so you can use it. There's beneficial with all types of volume contrast medium. There's beneficial for all racial population, but lower dosages in Asian patient. It is beneficial in patient with diabetes and patient with CKD. And it is more efficacious in patients with higher CRP and who have ACS. There is some still uncertainties with statins. So there is efficacy in severe, the efficacy in severe CKD with EGFR less than 30 is not assured yet. Efficacy in elderly patient, 75 years and above, and efficacy in non-cardiological diagnostic and therapeutic procedure requiring contrast, we are not sure about it. So this is just a summary for the guideline recommendation for the European recommendation for preventive measure against contrast-induced acute kidney injury. And you can see here in some of the guidelines in 2019 and 18, they recommended the high dose that we use with the cardiac procedure for prevention of MI or for the management of ACS. It can be used, although the other guidelines like KDIGO and NICE and the American Heart Association and the American Cardiology did not recommend it. How about the other intervention like herbal medicine? We have there are multiple trials. They used herbal medication like green tea, garlic, grapes, ginger, and others. And most of these studies show preventive and improvement of the effect of this herbal medication against contrast-induced nephropathy. But the effect was mainly seen in the laboratory setting, and there was no much benefit showed in real clinical trials. maybe because of the study design limitation or other factors, but they found signal in the laboratory studies. Now we'll talk about our experience with the contrast with the new agent. This is a study that was published. We did the study in our hospital. So the aim of the study that we wanted to see the effect of omega-3 fatty acid to reduce the risk of contrast-induced nephropathy in patients who undergo coronary angiography, and it was a randomized controlled trial. It was a single study center, and we used block randomization. And our aim was we wanted to see if this intervention going to reduce the risk of AKI in patients undergo angiography. And we enrolled 130 consecutive patients who underwent the coronary angiography, and we randomized them as two arms. The first arm is 67 patients. They received an SI system, and the other arm, they received omega-3 fatty acid, and both the group received isotonic sodium bicarb. This is just the baseline characteristic, and we can see that the age was around 66, and there was almost equal distribution between male and female. And we can see here the risk factors, the comorbidity distributed equally between the two groups, and the also the ejection, the patient who have heart failure, the ejection fraction was distributed equally between the two groups. And if you look here, we can see the primary outcome and secondary endpoint in this table. And we looked at the primary endpoint, if there is a rise in the creatinine more than 44, or there is an increase more than 25% from the baseline. And we looked at secondary endpoint, need for renal replacement therapy, death, or MI, stroke, or if there's a length of, or we looked at the length of an in-hospital stay day, and it was calculated as days from contrast administration to discharge. And we can see here there was no big difference between the intervention group and the N-acetyl cysteine group. Just in this graph is again another just representation of what we mentioned, and we can see here the p-value between the intervention and the control. It's almost similar. So we conclude from that trial that the short-term prophylactic use of omega-3 fatty acid with hydration does not reduce the risk of contrast-induced nephropathy or the need of renal replacement therapy, hospitalization rates, or death in patients with chronic kidney disease undergoing coronary catheterization. With this, I would like to thank you, and I will stop
here. Thank you, Dr. Khalid. It was a very nice presentation. It is very nice to know that we can use some simple things like ginger and green tea for prevention. But do you think we can advise the patients to do this?
Well, unfortunately, from the clinical trial, it was not positive. So although that it was just from laboratory studies on animals, it was effective. But I think we need larger study with better design to see if there is a real effect from these measures.
Okay, and what about metformin and the use of ACE inhibitors? Can we stop or keep on them? This is one of the questions.
Well, yes, if we remember the Mehran flow diagram, it depends on what's the risk assessment for the patient. So if patient is high risk factor, it's better to stop this medication. And if the patient is low risk factor, you can continue. Of course, you will give the hydration as part of a prevention for both groups.
Previously, there was recommendation about theophylline. But,
the evidence behind theophylline, it's not strong as the others. Like even they consider using some dopamine and phenodopamine and the others that try to increase the perfusion to the kidney and try to minimize the medullary hypoxia and damage. Unfortunately, all of them, they do not have a strong evidence to support their use.
There was some data about use of ACE inhibitor or ARBs that it may be protective, but it was not conclusive data. Did you read about this?
Well, I did not come across that.
Because
I think we have, when we look at these studies, so we have to look at the baseline characteristic of the patient they enrolled in the study. So if I give ACE or ARB in patient who does not have CKD and does not have other risk factor, yeah, of course, it will not, it might be good to continue. But patients, for example, who have low ejection fraction, low blood pressure, and other multiple comorbidities or risk factors, I would be careful to use ACE or ARB unless I have a strong evidence. But things are changing now, because you remember that CKD, we used to stop, for example, ACE and ARB if patients reach a CKD stage 4 and 5, but now the evidence is supporting to use them and continue.
Yes.
I cannot say for sure that it is contraindicated completely, but we are working with the available data that we have now.
Okay. Because it was a small study, it goes to what is behind the mechanism of ACE inhibitor and the ARBs. It says that we have afferent arteriole, glomerulus, then efferent arteriole, and this efferent arteriole is supplying the medulla and the tubules. So if you will stop the ACE inhibitor, it will make, we will lose the vasodilator effect of the efferent arteriole. So if it will be vasoconstricted, it will affect the blood supply of the medulla and the tubules. And based on this mechanism, they think that it may be protective to keep the ACE inhibitor and don't stop it in risky patients. This is what I heard, but it was a small study in not a reputable journal, just small.
Yeah, it might be by theory. It makes sense by theory, but sometimes there is some mechanism that overlooked, or sometimes the mechanism that we know it's more complicated than what we know or see. So again, I would like to wait for a larger study so we can use it for sure with recommendation.
Okay, I think, can you hold with me for 1 minute, because Dr. Mohammed Al-Quaiter has a problem in connection. If he still suffers from the same problem, we may give you the floor to give the second presentation, okay? Just give me a few seconds, okay? Alhamdulillah, we solved the problem with the link sent to Dr. Mohammed Al-Quaiter. So Dr. Khaled, can you stay with us for 30 minutes to give the chance for Dr. Al-Quaiter to give his presentation, then we'll come back to you. And I know that you're friends, and I am happy for having both of you in my screen right now. Dr. Mohammed Al-Quaiter, you are using a special link. I send it to you rapidly now, so you may rename from the right side up to rename the presenter, because it is on my name. So Dr. Mohammed Al-Quaiter will give us now the first presentation. It is updates in management of diabetic kidney disease.
Assalamu alaikum.
Dr. Mohammed Al-Quaiter is a consultant nephrologist, King Khaled University Hospital. We are happy to have you here for the 7th year, and inshallah for many returns, inshallah. Thank you, Dr. Mohammed.
Thank you so much for you, Dr. Ahmed, and the organizing and scientific committee for inviting me. I'm honored and so happy actually to be with you today. Do you see my screen, by the way? Is it clear?
Everything is clear, and it
Great.
is
right.
full screen, no problem.
That's great. So I'm gonna touch base today on the management of and on the updates about the management of diabetic kidney disease. I'll touch base on the glycemic control, the blood pressure control very quickly, as well as the use of ACE and ARBs. Then we will talk a bit about the use of SGLT2 inhibitors, the GLP-1 receptor antagonist, and the phenylenone as well. Let me start with this. When I say renal outcomes, or when you hear me saying renal outcomes, the renal outcomes in the clinical trials is actually a bit variable between the studies. Some would consider the cardiovascular death, for example, as one of the items that is included in the renal outcomes. Whereas in other trials, as you will see, inshallah, in the coming slides, they will consider cardiovascular events, death, as a secondary outcomes, and they'll concentrate only on end-stage renal disease, doubling serum creatinine, worsening GFR, and worsening albuminuria. Okay, so let me start with the first item of my talk, the glycemic control. There is no actually update, to be honest, about the glycemic control. I just remind you of this. In 1993, we had this randomized clinical trials where they actually randomized the 1,400 patients into two groups. The first group was targeting a 6.05% of hemoglobin A1C versus 9.1%. Those patients with intensive management, the achieved level was 7.3% of hemoglobin A1C. At 6.5 years' time, they found the following. They found that the albuminuria, the microalbuminuria, has decreased significantly by 39% in those patients who have been managed intensively. Macroalbuminuria as well has decreased by 54% in those patients managed with intensive therapy in comparison with those patients who haven't been managed with intensive therapy, but standard therapy. Several years after that, in 2011, there was enough time to comment on the GFR, not the albuminuria, which, as we know, it's not a solid outcome. It is a soft outcome, I would say. But the hard outcome from nephrology standpoint is when we see an effect on the creatinine, on the GFR, on doubling serum creatinine, on the incidence of end-stage renal disease. This extended study showed actually that those patients who have been treated aggressively, who were able to achieve a 7.3% control or target A1C, they found actually that they have better renal GFR in comparison with those patients who haven't been treated with aggressive therapy. Those patients who have A1C of 9.1% did really bad when it comes to declining in the GFR. Okay, so we're done with the first one. We have to have an excellent glycemic control. The question is hemoglobin A1C valid in chronic kidney disease? Can I rely on it? When I see an A1C of 7 in patients with advanced kidney disease, can I say that this patient has a well-controlled diabetes, for example? Well, don't forget these things. Keep in mind that metabolic acidosis actually will tend to increase the A1C, or let me say it in other way. When you have metabolic acidosis, A1C will be higher than what it's supposed to be. So that might give you a false impression that the diabetes is not controlled, while in reality, the diabetes was controlled, but because of acidosis, the A1C tended to be high. So this is a bias, but toward the high level. Anemia can affect the A1C. Hemoglobin, of course, low hemoglobin can affect the A1C. Using erythropoiesis stimulating agents can also underestimate the hemoglobin A1C. Keep that in your mind when you interpret hemoglobin A1C in patients with diabetes. As we know from a previous study, which included 50 patients, 25 with diabetic nephropathy, and other 25 actually with no nephropathy. Just 1 second. Yeah. They found that actually A1C is not correlating very well with the, or let me say it in another way, the glycemic control is not correlating very well with A1C when the patient has a GFR of less than 30, This is a pilot study, only 50 patients. In those patients, actually, the hemoglobin A1C were significantly lower in CKD patients relative to non-chronic kidney disease patients at a comparable glucose concentration. So if you have the same glucose concentration, if you have CKD, the hemoglobin A1C tend to be lower than those patients who have no renal disease at all. In this study, however, that is published in 2020, again, pilot study of only 100 patients with type 2 diabetes mellitus, they divided the patients into two arms. Patients, I'm sorry, again. So we have 104 patients, 80 patients with GFR of less than 60, and maybe around 30 or 24 patients with GFR of more than 60. In those patients with GFR of less than 60, 22 patients have a GFR of less than 30, but not yet on dialysis and not yet on erythropoiesis stimulating factors or agents. So again, we have 100 patients, 80 GFR of less than 60, around 25 GFR of more than 60. Those patients with GFR of less than 60, the 80 patients, out of them, 22 did have a GFR of actually less than 30, okay? And what was the result at the end of the study show? It showed that there is not really much of bias by the GFR, even among those patients with low GFR of less than 30. So what do these two trials tell you? It tells us that, yes, we still use hemoglobin A1C in advanced kidney disease, okay? But we have to read it carefully and interpret it carefully when the GFR is less than 30, okay? Probably the continuous glycemic control in cases where you are not sure about the diabetes control would be the best option to go for those patients. Now, what is the target in advanced kidney disease? Here is the recommendation. We recommend using A1C to monitor the glycemic control in patients with diabetes and chronic kidney disease in general. However, the accuracy and precision of A1C measurement declines when GFR becomes below than 30, particularly in patients on dialysis, in whom A1C measurement have low reliability, okay? So we should interpret the A1C in these cases with limitation in mind. Okay. Okay, so what is the target? What is the target for those patients? The target for chronic kidney disease with diabetes who are not yet on dialysis is between 6.5% and less than 8%. That depends actually on several factors. The severity of chronic kidney disease. So the bad the kidney is, the less the higher A1C target you will look for. I will not target an A1C of 6.5% or less in those patients with stage 5 chronic kidney disease, for example. Also, if you have macrovascular complications, or if you have other comorbidities, or when you expect the life expectancy to be short, then we will actually tend to target a higher level. And the American Diabetic Association actually is in line with what we have said in the KDIGO guidelines of 2022. They said the target is 7% in general for the population. However, there are several factors that I have to keep in mind: the comorbidities, the life expectancy, the risk of hypoglycemia and fall, etc., the age of the patient, etc. Okay, so the bottom line, it depends on the comorbidities you have in your patients. If your patient is old, let's say, and has significant comorbidities, reaching dialysis, then you may target 7.5%, or even 8%. Okay, how about the continuous glucose monitoring? It's still probably the better option to monitor the blood sugar if you are in doubt in those patients with advanced kidney disease when the GFR is less than 30. Okay, now we'll move to the third item, the use of ACE or ARBs. There is no new things about it. Okay, the guidelines in 2020 and 2022, the latest one published recently by KDIGO, we still recommend using the ACE or ARBs to be initiated in patients with diabetes, hypertension, and albuminuria. So if your patient is diabetic, hypertensive, and albuminuria, we have a reasonable and fairly good level of evidence to support the use of ACE or ARBs. Examples: well, captopril study for ACE in 1993, microhob in 2000. For ARBs, the IDNT in type 2 diabetes mellitus, the renal in 2001, the ERMA trial in 2001. Okay, level of recommendation 1B. Tough question. What is the blood pressure target? Well, the target is less than 130/80. Okay. However, you may argue with me that the ACCORD trial, where they included diabetic patients, they found that actually that there was no difference between targeting 120 versus 140. Okay. I see your point. For sure, the blood pressure should be less than 140/90, I would say. Okay. However, if you are able to achieve a blood pressure of less than 130/80 without a possible side effects, without a possible risk of fall and fracture, then yes, we'll target the less than 130/80 blood pressure. Okay, I'm going to talk about that. Let's now move to the anti-hyperglycemic therapies in type 2 diabetes mellitus. Everyone is talking nowadays about the SGLT2 inhibitors. SGLT2 inhibitors, as we all know, have actually an overwhelming evidence for use in diabetes for its amazing and really good cardiovascular and renal protective effects. How SGLT2 inhibitors work? Well, when you have actually, as we all know, there is a sodium glucose co-transporters that help reabsorbing the sodium and glucose. In diabetes, you will have a lot actually of sodium glucose co-transporter activation, and as a result, you will reabsorb a lot of glucose and a lot of sodium in patients with diabetes. So what would happen if it is the case? when the filtered load reach the macula densa, the macula densa will sense that I really do not have here any sodium. The sodium is low, okay? And why the sodium is low? Because SGLT2, the sodium glucose co-transporters, are so much active in reabsorbing glucose and sodium. There will be no sodium delivery. If you have no sodium delivery, our body will think that actually we are in a setting of volume depletion. So what would happen? It will increase the afferent arteriole. It will increase the afferent arteriole. When you increase the afferent arteriole, you will increase the intraglomerular, sorry, not increase, you will dilate the afferent arteriole. When you dilate the afferent arteriole, you will increase the intraglomerular pressure. Intraglomerular pressure increment will lead to an inflammatory cascade, maybe cytokine release, etc. So what should we do? We should maybe block the reabsorption of glucose and sodium. Maybe if we block the reabsorption, we will allow more sodium actually to reach the distal tubules. And here the macula densa will sense, okay, I think we have good amount of sodium here, all right? So it will give a feedback to glomerulus that we probably don't need, we are good, so let's vasoconstrict the afferent arteriole. We don't need the afferent arteriole to be dilated anymore, okay? This is the tubulo-glomerular feedback will be restored when you give patients SGLT2 inhibitors. Okay, I hope I explain it well. I'm sorry, I'm in a rush because we don't have much time as the lecture is only 30 minutes. Now, what do we have? What kind of evidence we have for SGLT2 inhibitors? I'll go over them quickly. We have the first one, the Credence trial. Credence trial that was published in 2019. The canagliflozin was tested with a primary outcome of kidney-related outcomes. So the primary outcome was doubling of serum creatinine, interstitial disease, and look at that, death due to cardiovascular or kidney diseases, okay? Credence included cardiovascular death in the primary outcome. Other studies did not. Okay, so around 4,000 patients, they randomized them. If you look at the GFR in Credence trial, the GFR was not that bad. So you're talking here about mean GFR of 57, stage 3 CKD. And they randomize it, randomize the patients into two categories, the canagliflozin versus placebo, on top of course, the ACE and ARBs. And look at the result. There was a significant, actually, reduction in the primary outcome for patients who have received canagliflozin. The number needed to treat was only 22 in comparison with 42, the number needed to treat is 21 to achieve the primary outcome, and the number needed to treat to prevent interstitial disease was around 42. Okay, so that was the first study that looked into the renal outcomes as a primary outcome and was successful in showing that canagliflozin decreased the primary outcomes and the incidence of interstitial disease. Okay. 1 year after, dapagliflozin, the DAPA-CKD study was published in New England Journal of Medicine. And again, they included 4,000 patients, type 2 diabetes, and they randomized the patients into dapagliflozin 10 versus placebo, and they followed them for about 4 years. And the primary outcome was renal, basically, and as well as cardiovascular death were included. And here were the results. Here are the results. It found actually that at 2.4 year old, that all causes of death is actually less in those patients who have received dapagliflozin. Death from any cause as well. The renal composite outcomes of doubling serum creatinine and end-stage renal disease also showed a significant reduction with dapagliflozin. Okay, so that was another evidence that dapagliflozin and other SGLT inhibitors showed a significant reduction in the primary renal outcome. Okay. So these are those studies where the first two studies, 2019, 2020, were looked into the renal outcomes as a primary outcomes. We have a study that was published in 2015, the EMPA-REG study, but the renal outcomes were secondary outcomes. So the first two trials that showed benefits of SGLT2 inhibitors as a primary renal outcome were dapagliflozin, the DABA-CKD, and credence. Okay, how about the very recent one was published a month ago, تقريبا, or 2 months, in November, the EMPA kidney studies. Well, to make it short, it actually showed the same. The difference that those patients have an advanced kidney disease, not like credence. Credence, the mean GFR was 57 actually, where here most of the patients have low actually GFR. And when it comes to progressive kidney disease, hospitalization of any cause, empagliflozin did much better than placebo. And because of that, they actually stopped the trial early before it ends because of the significant benefits. All right, so credence, DABA-CKD, and I will add EMPA kidney, because the guidelines, the EMPA kidney was published after the guidelines, where showed that those patients have good renal as well as cardiovascular benefits. However, there are other cardiovascular studies where it also showed that using SGLT2 is good in terms of hospitalization from heart failure, cardiovascular death as well. So with such a very convincing and overwhelming evidence, would you expect not a recommendation other than 1A, for example, for SGLT2? No, of course. Okay, now let's move to the second medications, the GLP-1 receptors antagonist. I'll show you this study, a systematic review, where they looked into the different GLP-1 studies. The GLP-1 studies, when it comes to composite kidney outcome, it showed in general a benefits. The benefits mainly driven from two studies, LEADER and SUSTAIN 6 and SUSTAIN 6. Okay. All-cause mortality as well, admission for heart failure as well. REWIND, however, was the only study that showed a significant renal protection, i.e. GFR-related outcomes. REWIND study, okay? Here, overall, GLP-1 were not good on or failed to improve the GFR or to slow the GFR in general. However, REWIND study, when you look only at REWIND study, there is some actually benefits. Okay, at what GFR level a GLP-1 receptor antagonist can be used? REWIND used GFR of 15%. That's why we still can use them as long as the GFR is 15% and above. How about the DDP4 inhibitors like linagliptin? Well, the only linagliptin that showed benefit, but this benefit was not that hard. It was only in terms of albuminuria. It was only in terms of albuminuria. However, was no difference when it comes to GFR. Sexagliptin, I'm not using it right nowadays, also decreased the albuminuria. However, it did not show any evidence when it comes to GFR. Okay, how about phenylenone, the non-steroidal mineral receptors, mineral corticoid receptors antagonist? Two famous studies. The first one, the Fidelio, published in 2020. They were able to randomize 5,000 patients, phenylenone 10 or 20 versus placebo. The primary outcome was kidney, okay, pure kidney. The secondary outcome was cardiovascular. And what did it show? It did show, actually, Fidelio, that phenylenone is better than placebo when it comes to the primary outcome, as well as the secondary outcome. So cardiovascular and renal protection. Okay. The second study that was published 2021, Figaro DKD study. So the Figaro DKD study, they didn't look at the renal outcome as the primary, but they looked at the secondary outcomes. The primary outcomes was basically cardiovascular. In this study, the Figaro DKD study, they found actually that there was not much of difference when it comes to renal outcomes. However, the cardiovascular outcomes was positive for those patients who have been treated with phenylenone. So we have two studies of phenylenone. The first one showed both cardiovascular and renal outcomes. The second one showed cardiovascular benefits. Okay. And for Figaro study, the significantly, positive things among the primary outcome was the hospitalization for heart failure. Okay. Again, there's a substantial small risk of hyperkalemia, but serious hyperkalemia is really not that significant. I mean, when it comes to the incidence, it's only 0.7%. So how about that? Protect the heart and maybe protect the kidney, but you will be at risk of serious hyperkalemia by less than 1%. Will you be able to take the risk? Will you take the risk? I will take the risk. Okay, so the hyperkalemia, although it's been reported, but it's much lower than the steroidal mineralocorticoid receptors antagonist, and the incidence is still low. I'm not going to talk about the fidelity. The management approach, how would we approach it? Well, we have to look into it into different levels. The lifestyle management, decreasing the weight, stopping smoking, doing regularly exercises, and as well as low protein and low salt diet. You have to keep your patients, if the patient is known to have or diagnosed to have diabetic kidney disease, on metformin. Why? It doesn't show evidence for renal protection, but it showed evidence for cardiovascular protection, and it's cheap and available everywhere. SGLT2 inhibitors for type 2 diabetes mellitus with subsequent renal impairment or albuminuria. RAS blockade, of course, and statin. Then you may consider adding these things. That it depends on several factors that we will talk about. And please do not forget controlling the other risk factors like blood pressure, like glycemic control, and lipid management. Okay. So the first line therapy in another slide, metformin, if the GFR is less than the GFR, we will give it on full dose if the patient has a GFR of more than 45, but if it's less than 45 and above 30, you will reduce the dose by half. If it is less than 30, of course, you will discontinue it. How about the SGLT2 inhibitors? At what level of GFR you will not initiate? Well, when the GFR is less than 20, you will not initiate. 20 taken from two studies, actually. The EMPA-Kidney, all right, and the Empower study in heart failure, I believe, where they used cutoff of 20 ml. So if the patient has GFR of less than 20, do not use SGLT2 inhibitors. Okay, when the patient reach dialysis, discontinue. Now, if the patient is obese, for example, and yet you're not able to control the diabetes, even though the patient's on metformin as well as on SGLT2 inhibitors, what to do? Here you may consider adding GLP-1 on top, okay? All right, this is for diabetic control, all right, okay. Yeah, metformin has 1B recommendation for its cardiovascular benefits, okay? SGLT2 inhibitors, as we said, has 1A recommendation due to the overwhelming kind of evidence we have. Which SGLT2 will you use? You will use the one that showed cardiovascular as well as renal protection. Which kind of SGLT2 that showed both outcomes? Dapagliflozin, empagliflozin, and canagliflozin. Okay, these things you have to keep in your mind when you want to initiate the SGLT2 inhibitors. If the patient is taking insulin or sulfonylurea, he will be at risk of hypoglycemia. So keep that in your mind. Keep that, educate the patients. You may actually consider decreasing the doses, okay? Especially if the A1C is within the target or at the lower target level. If the patient's on diuretics, for example, we know that initially SGLT2 inhibitors may cause volume depletion. So be careful when you start patients on SGLT2 if the patient is already on a good dose of Lasix or hydrochlorothiazide. You may start with the small dose and then you increase the dose subsequently. Good thing you have to educate the patient about, hypoglycemic symptoms, glycemic control when you start the A1C, the SGLT2, and also about the dizziness and reduction of the diuretic dose. One more thing, in the sick days, when the patient gets sick, having vomiting or nausea, might be wise actually to hold SGLT2 inhibitors until he's back to his usual state. Okay. Will you stop SGLT2 when GFR is less than 20? No. Why? Because actually there was no signals of harm based on DAPA-DKD study. They continued using it until they reached end-stage renal disease, initiated the renal replacement therapy, then they actually held it. So if it happened to start your patient on SGLT2 at a GFR of more than 20, and then the GFR continues to decline, do not stop it. You can continue using the SGLT2, maybe for its cardiovascular benefits, until the patient reach dialysis. In dialysis, we don't have data, so it's better to hold it. I'm sure we will have data on the use of SGLT2 inhibitors in the coming few years for those patients who are on dialysis. How about transplant? We don't have yet good evidence to consider using SGLT2 post-transplant. Why? Because those patients are immunocompromised and they tend to have more infections. SGLT2 will cause glucosuria and may increase the risk of UTI and may increase the risk of genital infection as well. So it's better to hold it until we have safety data on renal transplant. Okay. What is the evidence for GLP-1 for patients with diabetes and diabetic chronic kidney disease? It is actually 1B. Okay. If the patient have used metformin, have used SGLT2, and yet we have obesity or we have uncontrolled diabetes, please introduce GLP-1 receptors antagonist. Okay, how about finerenone? Where will you fit finerenone in that actually approach? Do we have evidence for combination, finerenone and SGLT2 inhibitors? If you see Fidelio study, only a small number of patients were using SGLT2 or using GLP-1, okay? And as well in Figaro study, only 8% of patients were using SGLT2 inhibitors. What does that tell you? It tells you that we don't have evidence, solid evidence to draw a solid or strong conclusion. Okay, you can use it. Yes, you can use it in combination. Yes, I agree with you, especially when you still have an albuminuria going on, despite of using the ACE max dose and SGLT2, and yet you still have albuminuria, you may consider using finerenone. But is that high-level evidence, or does that have high-level evidence? No. Until now, no. There is an ongoing study called Confidence Trial. They want to actually give the combo of IMPA and finerenone and see its effect on albuminuria. It's expected to be published in 2024. I wish they actually looked for a harder outcome like doubling serum creatinine or cardiovascular death. Okay. So since we have only 2 studies, one of them were positive for renal protection, they gave the finerenone 2A level kind of grading. Okay. So for type 2 diabetes mellitus, give metformin, give SGLT2 inhibitors, give RAS, okay, moderate or high intensity statin, right? You have a problem, still blood sugar is not controlled, and patient is obese, you may consider adding GLP-1. Actually, you still has albuminuria, you may add finerenone, okay? By adding GLP-1, you still have a problem in controlling the diabetes. Here you may think of insulin, linagliptin, etc. Okay. Since there is substantial risk of hyperkalemia, keep in your mind that if your patient has a potassium of less than 4.8, then you can initiate finerenone, okay? If the potassium is 4.9 and 5.5, despite of on using finerenone, then you can continue, but monitor the potassium every 4 months. When it's more than 5.5 while using finerenone, then stop it, please. And reconsider holding it for a while, decreasing the dose when the potassium is less than 5. I think I reached to the conclusion. I hope that I didn't take a long time. Thank you so much, and I'm happy to receive any questions.
Thank you, Dr. Muhammad. I'm checking the questions. Currently, there is no question. And it's time for Dr. Khalid Al-Mawsim once again to talk about updates to talk about vasculitis management. Thank you, Dr. Khalid, for staying with us. And we will come back for Dr. Al-Khwaitar again after you finish, inshallah.
Okay, thank you, Dr. Ahmed. I need to share my slide. Maybe I think Dr. Muhammad need to stop sharing.
Yes, sure. Yes, okay. We stopped sharing already. You can start sharing your screen.
Okay, so
it is clear now. Just make a full screen.
Bismillahirrahmanirrahim. Okay, thank you, Dr. Ahmed again. And it's always difficult to speak after Dr. Muhammad Al-Khwaitar with his nice presentations. I'll talk about the ANCA-associated vasculitis. Here's the outlines. Talk about classification of vasculitis and kidney focus, mainly diagnostic and therapeutic principles, and the new treatment developments. For the classification, as you know, vasculitis is the inflammation of the vessel walls. And we are familiar with the vasculitis, which is considered or classified according to the predominant size of the affected blood vessels. And the classification and nomenclature has undergone multiple revision throughout the literature. I'm sure all of you are familiar with this classification for large vasculitis, large phase vasculitis, medium and small. And mainly I'll talk mainly about the small vessel vasculitis, and it can be either immune complex deposition causing the vasculitis, or it can be post-immune vasculitis, and this is what we call ANCA. Just this is another representation of the previous slide, and if we see here, this is just the distribution of the vessels. of the vessels affected by the, and mainly you can see in the kidney, it can be medium vessel or small vessel, as you know. Here is just in this, in one study, they listed the most common causes of vasculitis, regardless of the size of the vessels affected. And if you can see here, the small vessel vasculitis, it has the largest number of causes, either including immune complex vasculitis or post-immune vasculitis. So reaching the correct diagnosis is really important to know what you are dealing with and providing the right therapy. And if we see the small vessel vasculitis as a group, it is usually necrotizing vasculitis where it has very few small immune deposits, affect the small vessels like capillary, venous, arterioles, and small arteries. And it is usually associated with either myeloperoxidase or proteinase 3 ANCA. And ANCA patient might have antibodies against different epitopes, not necessarily the MPO and proteinase. Here, if we look, just this is the differentiation between the main small vessel ANCA. If we know the microscopic cholangitis, it is necrotizing vasculitis type, it's post-immune, and the glomerulonephritis is very common in those patients, and the pulmonary involvement is frequent. And the inflammation is not centered around the vessels, and the granules are not common. While the GPA, granulomatous cholangitis, it is necrotizing and glomerulomatous vasculitis. It can affect upper and lower airway, and GN is very common. It can cause pulmonary hemorrhage, and ocular involvement is frequent. Also, the extra inflammation is common, and the granuloma present, but not always visualized or captured. Sjogren-Strauss or eosinophilic polyangiitis, usually it's eosinophil-rich necrotizing type. It affects the respiratory tract often, and they sometimes present with asthma and eosinophilia, and more than 10% of the patient. And it has ANCA is strongly associated with GN, and the extra inflammation is common, especially in the lungs, myocardium, and GI tract. Just this is the main differences, and I just would like to emphasize that MBA is not associated with glomerular inflammation. About the ANCA association, it's positive in 90% in the GPA, and usually it's directed against PR3, and MPA it's almost 70%, and it's more of the MPO type, but you can have either, of course, either in GPA or MPA, and in Sjogren-Strauss, the ANCA is positive in around 50% or less, and it's more of the MPO type. How about the other type of, or small vessel vasculitis, but non-ANCA, and the real relevance? This is what we call immune complex GN, and it's common, mainly it's like anti-GBM disease, and you can have pulmonary and renal involvement, and you can have dual disease with ANCA at the same time. You can have small vessel vasculitis due to systemic disease like SLE or lupus or rheumatoid arthritis. You can have cryoglobulic vasculitis. It can affect the skin, peripheral nerves, and it can cause glomerulonephritis. IgA or HSP, it can involve the GI system and the skin, and it can involve the kidney. These are just some of the most common of the small vessel vasculitis, which is not ANCA related. Now let's talk about the diagnostic and therapeutic principles. For diagnosis, urgent recognition is the key, actually, because this is a significant and aggressive disease. And if you delay the management just to reach the diagnosis, if it's not available, then you are wasting time and losing more tissue. And a tissue diagnosis is not always required and should not delay the therapy. So if you have a clinical picture with positive antibodies, you can proceed with the management, especially now in most of the centers that you can get the ANCA result within 2 hours. So there is no need to wait for for a few days to get the result back. And mainly maybe the tissue diagnosis is important for prognostic information. You have to know that in renal biopsy, vasculitis and granuloma may not be evident all the time, just you see post-immune glomerulitis. And the diagnostic principles, according to the UFAS groups, it requires chronic inflammatory disease lasting at least 4 weeks, exclusion of other causes such as infection or malignancy, supported by characteristic histology on the biopsy, and or a positive ELISA for PR3 or MPO antibodies, and a classical ANCA on immunofluorescence. Other definitions often are used for research purposes. So mainly this is the most common, as I mentioned, it's a clinical diagnosis and you can confirm it by the antibodies. Of course, if you have the histology, it will be a great thing. And when you evaluate patient plan therapy and response therapy, it is important to consider a classification and evaluate the activity of the disease. Now, let's talk about the therapeutic principles that we have. So for autoimmune disease in general, we talk about 2 phases, the induction and we talk about the maintenance. And for the induction, we want to control the disease with goal to induce remission. So we need a drug that it is effective and it works fast to achieve the remission. And steroids so far are considered the cornerstone, but as monotherapy, it's not sufficient. So you have to use another agent for induction. But of course, it works within few hours and it can buy you sometimes, so you can initiate the other inductive therapy. And now we have several options that we can use as second agent for induction. Maintenance, of course, it's maintaining remission while minimizing the toxicity of the treatment. For induction, if we look at the level of evidence, what we have so far, we have, or what we have approved literature so far, we have the steroid as 1A. And remember that steroid by itself, it's a good agent for induction, but it does not work alone, and it carries a lot of toxicity and complication for the patient, especially here in our population who have diabetes. We saw a few patients in our practice who got diabetes or steroid-induced diabetes. So we try to minimize the treatment as much and as fast as we can. Cyclophosphamide, either oral or IV, it is 1A. Therapy, rituximab, 1B. Of course, now it's 1A, and plasma exchange. I will talk about it down the road. Here's just in this table, summary of all the multiple trials that was used, and it's not enough. There's more trials that is not included here. All are talking about the management of vasculitis, either renal or extrarenal manifestation. They use different agent for management, and I will not go through this. Just want to show the name of the trials that we have. So we have extensive work to treat this aggressive disease. Now, if you look at the steroid, we will give a pulse steroid or IV methylprednisone between 0.5 gram to 1 gram daily for 3 days, followed by 1 milligram per kg per day between 60 and 80 milligram a day. And we'll give it for 2 to 4 weeks, high dose prior to evaluation, and we plan for taper. And from the literature that we've seen so far from lupus and other trials, that the people who have lower steroid, maybe they did better in the control of the disease, and they have less side effect in comparison to the other group. And the overall goal is to minimize it by 6 months but final taper is slow, below 10 milligram. And of course, this is controlled or guided by the patient response to the management. How about the other inductive agent? We have cyclophosphamide, and we have different trials confirming the efficacy. One of them is an NIH study, which is established the rule for second agent in ANCA vasculitis. It's a prospective non-randomized trial. They used oral cyclophosphamide as 2 milligram per kg per day and prednisone. And you can see that 85% of patients who receive this cyclophosphamide achieved remission in comparison to the placebo, and it was statistically significant. So the question was, can we minimize the cyclophosphamide exposure, because as you know that the dose that we use with oral usually is higher than the IV. So the cyclop trials, it is a large multi-center prospective randomized control trial. They used IV cyclophosphamide versus the oral cyclophosphamide for induction of remission, and they included 144 patients, and they were all have a serum creatinine less than 500 micromole per liter. And you can see more than 90% of the patients achieved remission, and 75% of them, they achieved complete remission. So IV cyclophosphamide is effective as oral cyclophosphamide in comparison for the management of ANCA vasculitis. Just a couple of things we have to keep it in mind when you use cyclophosphamide, that we have to adjust according to the age and according to the serum creatinine. How about the new agent, the rituximab, that was introduced? And the recent trials showed that rituximab is effective as inductive therapy agent. We have the two trials, the RAVE and RAVE trial. They compared rituximab with their oral cyclophosphamide for induction of remission, and the rituximab trial compared rituximab plus 2 to 3 IV cyclophosphamide doses versus the IV cyclophosphamide. Just I want to mention that rituximab is anti-CD20, and you can see here that if we want to inactivate a B cell, we have different receptors that we can work on. We have the anti-BAF, we have the CD40, we have the CD79, and the BCR receptor and the CD20 receptor. Okay, so of course, rituximab work here, and the other therapies, they are working on different places. If we look here on this is a summary and comparison between the two groups, and we can see here that in this trial that on the left side, they included patients who have ANCA vasculitis with Birmingham vasculitis score more than 3. They exclude patients with high creatinine, or patient who have alveolar hemorrhage requiring ICU. Here in this trial, they included patients who have a new vasculitis and renal impairment. Of course, the control arm, they used prednisone with oral cyclophosphamide, while on the other trial, they used prednisone with cyclophosphamide IV Q2 weeks for 2 doses, then Q3 weeks, followed by azathioprine. The treatment arm, they used prednisone plus rituximab, and for this trial, they used prednisone and cyclophosphamide IV for 2 weeks for 2 times, then plus the rituximab for 4 doses. If we look at the trial design here, it is double-blind RCT. It is non-inferiority study, and here it's open label RCT. And they looked at the primary outcome in this trial, the BRAVE at 6 months, and in the rituximab, they looked at the sustained remission at 12 months. If we look here at the study results, we can see here at 6 months, the PFAS 0 and being of prednisone, it was achieved in 64 in comparison to 53%. So it was not, it was non-inferior, but it shows non-inferiority, but did not show superiority. And the relapsing disease was 67% in comparison to 42% in REACH primary outcome of the superiority analysis. If we look here at sustained remission, it was achieved in this trial of up to 72% in the treatment and 82% of the control group. So it was not significant here. Of course, in the trials, it's important always to look at the side effect, and the adverse event was 27%, same in both the group, and infection was 7% in both the groups in the RAVE, while rituximab, the adverse event was 42 of the treatment group and 36 in the control group. Infection rate was almost similar, and the death rate was similar in both groups. So in general, in mild disease, rituximab is not inferior to cyclophosphamide and in mild relapsing disease, rituximab is maybe superior with mild renal disease. And in the rituximab, it was a small superiority study with a negative result and more. They have more severe disease or renal disease. So this was for the induction part. So it is effective as an induction, and they looked at the subsequent group. It might be effective for relapsing disease from subgroup analysis, and it might be good for patients who have PR3, more active and refer to ANCA negative after the use of this medication. And then they have the RAVE extended trial for almost 18 months. And from that study, it showed that rituximab, it can be used as maintenance therapy to maintain the remission of the ANCA vasculitis. We have also the other trial, main Tristan trial. They used rituximab to maintain the treatment, and it was also effective. How about the long-term safety? So for how long I can use rituximab for maintenance? In this study, they looked at 3,000 patients, and they followed them up for 11,000 patient-year follow-up, and they observed almost 627 patients for more than 5 years observation, and up to 17 courses of rituximab was used over 9.5 years. And we can see that there is comparable risk of adverse event to patient on biologics. And we can see the risk of BML was only 6 cases confirmed and estimated patient who used the rituximab. How about the plasma exchange evidence in patients who have ANCA vasculitis? This is an area for controversy, and the previous recommendation mentioned that it should be used for pulmonary hemorrhage patient and severe creatinine or patient who have anti-GBM. So on this trial, this is a PIXIFAST trial. It is open label in 16 countries. They included ANCA vasculitis patient with the patient who have eGFR less than 50 and pulmonary hemorrhage in 700 patients. They randomized patient to plasma exchange for 7 sessions, and patient, the other arm did not receive plasma exchange. And they also randomized them to a standard steroid therapy and reduced steroid regimen. And we can see here, this is the primary outcome. They were looked at death or reaching end-stage kidney disease, and also they looked at the severe infections. And we can see here as a conclusion from this studies that patients who have severe ANCA vasculitis, the plasma exchange did not reduce the incidence of death or the end-stage kidney disease, but a reduced dose of steroid was non-inferior to the standard dose regarding reaching end-stage or death. So this is again supports the approach to reduce the risk of or the use of steroid. A new therapy which was introduced was the avacopan, which is C5a receptor inhibitor. And if you can see here, this is the pathway for the complement activation that you are familiar with. And the C5a receptor inhibitor, it works actually here. And all we are familiar with the C5 inhibitors. We talked about ocrelizumab and it's working, and we heard about it in the last few years about the effect in atypical HUS, and we have some evidence in the transplant, and Dr. Sami Bib spoke about it in the first lecture. The problem with usual inhibition of this C5 pathway and the MAC or membrane attack complex is that you will be severely immune suppressed and you might be at risk of infection. So the avacopan, how does it work? It actually, first thing, it avoid the long-term biological consequences of upstream complement inhibition in general, and do not block the C5b9 protection. So it does not leave the host defense mechanism membrane attack complex in place. So you still have the MAC in place, and it can help with cell lysis, and it can protect the body. Also, it preserves the beneficial function of the C5L2 pathway, which is beneficial as anti-inflammatory effect, as you can see here. And it also targets the downstream complement pathway, you can see here. So it affects the leukocyte trafficking, migration, and activation. So we have the advocate study. It's a phase 3 study where they use avacopan, and the aim was to compare it to the steroid for the induction of treatment. So it's a randomized trial, 1-to-1. In the avacopan group, they enrolled 166 patients and similar number almost in the prednisone group. And here, this is the study design. They gave avacopan 30 milligram twice daily, and they gave also dummy prednisone for comparison because it's a blinded study. They gave cyclophosphamide for 13 weeks, followed by Imuran, or they gave rituximab for 4 weeks. And also here in this group, they give, in the control group, they give 60 milligram per day tapered to 0 over 20 weeks. And also they gave the same standard therapy, cyclo, followed by Imuran or rituximab, and they gave avacopan matching the placebo. The primary endpoint was at 26 weeks as to look at remission. And the second primary endpoint was sustained remission at 52 weeks. If we look here for the primary endpoint, 26 weeks, we can see here that in the avacopan group, people who achieved remission was 72% in comparison to the prednisone group, so it was not inferior. And we can see it here from this diagram. It does not touch the non-inferiority boundary. Also, at the second primary endpoint, which is avacopan, it was superior to prednisone in week 52 for maintaining the remission. So patient who reached 52 weeks with remission was 65% in the intervention group, while it is 54% in the prednisone group, and it's actually non-inferior and superior. And you can see it here on this graph here that it is in the favor of the intervention. So we can see here that avacopan it is effective for the induction, and it can help to minimize and to avoid the toxicity that we see with the steroid from multiple trials. And if we look at the safety profile of this medication, it has no difference or no significant side effect or infection rate in comparison to the others. With this, I would like to thank you for listening, and I'm more than happy to answer any question.
Thank you, Dr. Khaled, for this nice presentation. We have only one question for you regarding vaccination before avacopan.
Well, because it works in a way different than the eculizumab. I know both of them affect the C5 pathway. So I don't see a recommendation from the trials to be given. I know from eculizumab, we have to give the meningococcal vaccination 2 weeks before the administration of the drug. But I don't see a recommendation yet. It's a new drug. Maybe there will be a recommendation down the road, but up to my knowledge, there is no recommendation to give any vaccine so far.
Okay, thank you. Thank you, Dr. Khaled, for being with us for these 2 nice presentations. And inshallah, you will be with us in the next years and many returns, inshallah. Thank you.
Thank you, Dr. Ahmed, and thank you for the invitation and the organizing committee.
Thank you. So Dr. Muhammad Al-Khwaiter was the next presentation about pathophysiology of minimal bone disorders in chronic kidney disease. Thank you, Dr. Muhammad, and we are happy to hear again from you.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum مرة ثانية. Thank you so much, Dr. Ahmed, and thank you also for Dr. Khalid for his great lecture. I'm gonna touch base on the pathophysiology of mineral bone disorders in chronic kidney disease. The outline of my talk, I'm gonna talk about the key players in the pathophysiology of MBD and CKD. We'll talk about the consequences of abnormal phosphate, calcium, PTH, and abnormal FGF23 Klotho axis. And if we have time, we'll also talk about the impact of such changes on the clinical practice. So let me start with this slide, the phosphate balance between the influx and efflux. And to make it easy, what we eat every day is about 1,200 milligram of phosphate, okay? Eventually, what gets excreted through the GI tract is 1/3 of 1,200, 400 milligram. Whereas 2/3, which is about 65 to 70% of the phosphate get excreted through the kidney tract, through the kidney. Okay. So if it is the case, when the GFR drops, I would expect the phosphate level to start to increase. Why? Because 65% of my phosphate is supposed to be excreted through the kidney, right? Okay, what if you have an initial rise in phosphate? Is that bad? Yes, it is bad. Why? How? Well, high phosphate will lead to transdifferentiation of the vascular smooth muscle cells into osteoblast-like cells, which will result in calcification and hardening of the vessel wall. The question is, how would high phosphorus lead to these morphological changes and mineralization of the vascular smooth muscle cells? That could happen through two things. Number one, don't forget that the phosphate and calcium product is the main actually component of the mineral that you see in calcification and bone. And number two, high phosphate will trigger specific kind of protein production. The vascular smooth muscles in the context of high phosphorus will be triggered to upregulate a specific protein involved in the normal osteoblast formation. So basically the smooth muscle cells will transdifferentiate into osteoblast cells, calcification. Is calcification bad? Well, calcification will lead to the following. When it gets calcified, the large vessels, when it gets calcified, that will lead to arterial stiffness and hardness, and that will result in wide pulse pressure. And that would result in also increasing afterload and subsequent left ventricular hypertrophy. When the calcification happens at the level of the coronaries, that will lead to increasing the risk of myocardial infarction. That will increase the plaque burden as well. And when it happens at the level of the small arterioles, you will have calciphylaxis, calcific uremic arteriolopathy, very devastating, complications with very high morbidity and mortality. What if the calcification happened at the level of the valves? Well, that will lead to incompetency and subsequent heart failure. So would it be surprising to know that cardiovascular mortality is the leading cause of death in chronic kidney diseases? No, it's not surprising at all. In this report from the USRDS report 1997, see what I'm going to point at right now. This is the mortality, okay, and this is the age, Okay, those patients are the normal population. The mortality at age of 75 to 84 تقريبا for normal population is equal to the mortality for patients who are doing dialysis if they are actually between 25 and 34. So young dialysis patients in this report has significant mortality rate that is equivalent to the mortality rate of those normal population who are between 75 and 84-year-old. In another meta-analysis, they found that the worsening GFR you have, the higher the risk of cardiovascular mortality. At GFR of 45, at stage 3, the mortality is double. At GFR of 15, stage 4, the mortality is tripled. And in one report, actually, when the GFR reach, or when the patients reach end-stage renal disease, the mortality will be at least 4 times the normal. So yes, it is bad to have calcification. Why you have calcification? One of the proposed mechanism is hyperphosphatemia. Is hyperphosphatemia associated with increased mortality? Yes. High phosphate actually constantly found to be associated with increased mortality in all these trials. This is very consistent. Okay, so if it is the case, if high phosphorus will lead to maybe lead to mortality, what should our body react to that? How would we adapt to the initial rise in phosphorus? Well, basically, we have to enhance the phosphate excretion in order to normalize the phosphate level. How can we do that? By 2 things. When the GFR, when there is an initial rise in the phosphorus, the FGF23 will be stimulated, fibroblast growth factor 23, and also the parathyroid hormone, both of which will enhance phosphate excretion, and that will normalize the phosphate level. If it is the case, in order to maintain the phosphate level within the normal range, then FGF23 and PTH should rise early on to maintain normal phosphate, because 65 to 70% of your phosphate will get excreted through the kidney, right? And this is what is happening actually. FGF23 and PTH start to rise early on when the GFR drops below than 80. If it's not even drops below than more than 80 in some reports. Okay, look at this diagram. PTH and eGFR, start to go up early, very early in the course of chronic kidney disease. Okay. Question: how would parathyroid hormone and FGF23 act? How would it cause phosphaturia? Okay. In the proximal tubules, we have 2 sodium phosphate cotransporter. One cotransporter here, and the second cotransporter here. We call it sodium phosphate 2A and sodium phosphate cotransporter 2C. So 2A and 2C. Parathyroid hormone will actually take this cotransporter and internalize it inside the cells, and that will lead to endocytosis. So basically, PTH effect is by causing endocytosis, internalization of the cotransporter, and therefore cotransporter sodium phosphate 2A will not be expressed at the brush border, will not be expressed at the brush border. If it's not expressed on the brush border, phosphate will not be able to be reabsorbed. Phosphate will continue its way in the urine in the tubules until it show up in the urine. So PTH will cause phosphaturia as a result. How about FGF23? FGF23 will act on the both cotransporters actually, will decrease its expression. all right? And if you don't have, again, these co-transporters at the brush borders, the phosphate won't be able to get inside. The phosphate will continue its way through the urinary tract until it shows up in the urine. This is how FGF23 and PTH causes phosphaturia, by acting on sodium phosphate co-transporters and down-regulating them and decrease its expression. Okay. So that it seems that our body is adapting well with the initial rise and with the initial rise in the GFR and the initial decline. Sorry, when the initial rise in the phosphate and the initial decline in the GFR. Good job. However, when GFR drops below than 30, phosphate rise will be inevitable, no matter what the PTH level is, no matter what the FGF23 is. I can't handle the phosphate load when I have very low GFR, less than 30. Phosphorus will start to rise anyway. Okay. When I say below advanced kidney disease, I mean when it comes below than GFR of 30. Here, look at the phosphorus level will start to go when the GFR below than start to go down start to become below than 30. Okay, what are the consequences of high phosphorus? We just said that in the first or initial 2-3 slides. High phosphorus is linked with calcification, and that calcification is associated with mortality. High phosphorus is as well associated and found to be associated with mortality. High phosphorus will lead to increasing the binding capacity to the calcium. So you will have more calcium phosphate complexes, right? And high phosphorus will actually decrease the activity of 1-alpha-hydroxylase enzyme. Decreasing the activity of 1-alpha-hydroxylase enzymes and binding and complexing with calcium, both of which will result in hypocalcemia. Okay, how about the calcium balance, the influx and the efflux? In a similar way, 1 gram, 1,000 milligram is the expected daily intake of calcium. What you get through the GI tract at the end of the day is actually 80% of the calcium. What gets excreted through the kidney, only 20%. Compare that with phosphate. In phosphate, 65 to 70% of phosphate get excreted through the kidney. It is not the case with calcium, only 20%. Okay. So in advanced kidney disease, let's say that the normal phosphorus level is supposed to be here. Phosphorus will be significantly high when you have very advanced kidney disease. It will be significantly above the normal. Calcium may not be high initially because only 20% get excreted through the kidney. When that much of phosphorus bind to that much of calcium, the end result will be still hyperphosphatemia, but hypocalcemia. So this is one of the possible mechanisms of having hypocalcemia and chronic kidney diseases. Okay, so consequences, calcification, mortality, hypocalcemia, any other calcification, any other consequences? Yes, stimulating parathyroid hormone. Actually, phosphate directly stimulate the parathyroid gland and stimulate as well the proliferation of the parathyroid cells, okay? And phosphate will lead to high PTH indirectly by decreasing the 1-alpha-hydroxylase enzyme. When you decrease the 1-alpha-hydroxylase enzyme, you won't be having active vitamin D. And if you don't have active vitamin D, you will lose the negative feedback on the parathyroid gland. So hyperphosphatemia will cause indirectly high PTH through decreasing the activation of vitamin D. The other consequences of high phosphorus is continuous stimulation of FGF23. Okay, you're talking about parathyroid hormone a lot today. Yes. What are the consequences of high PTH? It's been found to be associated with mortality. Again, Okay, it will act on the bone, causing bone resorption and subsequent mineral bone disorders, which is really bad. High PTH will mobilize the phosphate from the bones, and high phosphate will stimulate the PTH, and so on. It will be like a vicious cycle, right? So PTH is no longer adapted in advanced kidney disease. It actually will be maladaptive. Okay. Causes of high PTH, several causes. We said hyperphosphatemia, the low activation of vitamin D, the hypocalcemia, which is the strongest stimuli of hyperparathyroidism. In addition, diminished calcium sensing receptors on parathyroid gland. In order to suppress the parathyroid gland, the calcium sensing receptor should sense the calcium, all right? If you have hypocalcemia, that will be a problem because the calcium sensing receptors will not be able to sense, the calcium sensing receptors will actually won't be enough saturated to suppress the parathyroid gland, okay? You may have good level of calcium, but the expression of calcium sensing receptor is diminished. So you won't be able again to suppress the parathyroid gland. One more thing, it was found as well that the vitamin D receptors also has been, diminished. Its expression has been diminished on the parathyroid gland. And if you don't have vitamin D receptors, you won't be able to sense the active vitamin D. And if you can't sense the active vitamin D at the level of parathyroid gland, you cannot suppress the parathyroid gland. Okay, how about FGF23? Well, FGF23 increases, as we said before, early on in CKD and then progressively. So you will get higher and higher and higher level as the GFR decline further and further and further. What could stimulate FGF23? Hyperphosphatemia and increased dietary phosphate load. In addition, maybe reduced renal clearance when you have very advanced kidney disease can contribute to the high FGF23. FGF23 produced by the bones, basically by the osteocytes and osteoblasts. How would it act? I'll show you how would it act. The FGF23 actually will bind to its receptors. FGF23 will bind to FGF receptors. In order to bind, you should have clodo, something called clodo. Clodo is a co-receptors, is a cofactor. What does it do? It increases the affinity of FGF receptors for FGF23. So FGF23 cannot work if you don't have enough clodo, okay? What is clodo? Clodo is expressed mainly in the renal tubules. It is also expressed in the parathyroid gland. Clodo increases significantly the affinity of fibroblast growth factor receptors for FGF23. Clodo deficiency and expression on parathyroid gland, maybe I'll skip that. Clodo decreases early in CKD and then progressively with decreasing GFR. Look at that. FGF23 increases early on. Clodo decreases again early on. So from the beginning, actually, you will start to have low clodo and high FGF23. Having high FGF23 and low clodo will be maladaptive, when you have significant chronic kidney disease. Okay. Consequences. Well, I shouldn't call it consequences of high FGF23. I should say consequences of having dysregulation of FGF23 clodo axis associated with cardiovascular mortality. FGF23 will decrease calcitriol by decreasing the activation of 1-alpha hydroxylase enzymes. Okay. Talking about calcitriol actually will decrease when the GFR drops below than 60. why the activation of the active vitamin D will be decreased. Several actually factors are playing roles here. So high phosphorus will decrease the activation. FGF23 will decrease the activity of 1-alpha hydroxylase enzyme, and eventually losing kidney function mass will affect its endocrinological function. One of them is producing 1-alpha hydroxylase enzyme. Okay, so let me summarize the things again. In chronic kidney disease, you will start to have an initial rise in the phosphate, and that will result in increasing FGF23 and decreasing chloro. In addition, high phosphorus will also stimulate the production of parathyroid hormone. Parathyroid hormone and FGF23 will enhance the phosphate excretion, will be good work, adaptive very well initially, but eventually will be no longer helpful. Actually, it will be maladaptive. Any effect of FGF23? Yes, it will decrease the activation of vitamin D. Also, hyperphosphatemia will decrease the activation of vitamin D, and that will result in hypocalcemia. Hypocalcemia will, and hyperphosphatemia as well, can contribute and cause hypocalcemia by binding with the calcium. Hypocalcemia is very strong stimulus for parathyroid hormone production. And don't forget that also low 125 hydroxy vitamin D will result in losing the feedback, decreasing 125 hydroxy vitamin D will cause positive feedback to the parathyroid gland, and that will result in increasing the PTH. I know it sounds complex. It is complex actually, but we're trying our best to understand it at our level and to make it also easy to understand or close to be understandable by others. Now we'll talk about the clinical implications of what we have said before. So I just said that hyperphosphatemia is associated with mortality. And also we said that hypocalcemia is found to be associated with mortality. We also said that high PTH is found to be associated with mortality. And we also said that high FGF23 is associated with mortality. How do you read that? Well, they are in the same cascade, right? They are in the same cascade. So I would expect all of them to be associated with mortality, but the question is, which one is the causative agent and which one is the marker of the disease? Very difficult question. Here, for example, if you look at the PTH, several studies, it showed that it's associated with mortality. Okay, other studies showed that there is no significant difference. Hypocalcemia, several studies showed that it's associated with mortality as well. Okay, high PTH, most of the studies showed that is actually associated with mortality. So for high PTH, most of the studies associated with mortality. Phosphate, all of these studies were associated with mortality. Hypocalcemia, several studies were found to be associated with mortality. FGF23, this is meta-analysis that showed that actually FGF23 is associated with mortality. Okay, so is it the phosphorus? Is the phosphate is the problem here? Maybe. And that's why KDIGO guidelines were advising to keep the phosphorus in 2009 within the normal range. Why? Because it's associated with cardiovascular mortality. However, there is no consensus about that. The KDIGO themselves, actually, they changed it from within the normal range to near normal range in 2017. Canadian Society of Nephrology, they said within normal range. KDUKI, they said below than 1.7. UK, below than 1.8, if you're using the millimole per liter, while if you're using milligram per deciliter, as you see here, okay? Japanese, between 3.5 and 6. There are different, actually, opinions. There is no consensus, right? Why there is no consensus? Let me ask you the same question in another way. Do we have an evidence saying that lowering the phosphorus will improve the survival? I know that high phosphorus is bad, but do you have evidence saying that when you give phosphate binders to lower the phosphorus, will that improve the survival? Actually, we don't have good evidence. That's why you see different opinions, okay? In patients with CKD stage 3 to 5, the KDIGO, they suggested that to lower the phosphate level toward the normal range. But look at the grade 2C, weak recommendation due to lack of evidence. I'm not saying that you do not decrease the phosphorus. No, we're still trying our best to decrease the phosphorus, right? I may take the 1.7 as the cutoff level. Some others might, go lower than that. However, by doing this, are we sure that we are improving the survival? This is the tough question. We don't know. We don't have evidence yet. Okay. This is a small pilot study, 104 patients. They randomized them into 2 groups. A group 2 target a phosphorus level between 2 and 2.5, and to target a phosphorus level, the intensive, between 0.7 and 1.5. The primary outcome was not hard outcome. The primary outcome was only the difference in the serum phosphate. Why they did not put a cardiovascular outcome as primary outcome? It is a pilot study. They can't reach to such a conclusion, but they included it in the secondary outcome. So in 6 months' time, they were able to achieve low phosphate level. So it is doable. You can do that. You can decrease it, okay? However, when it comes to cardiovascular death and events, there was no difference between them. Significant, a lot of limitations for this study. It is pilot, it is small, short-term study as well. Okay, how about calcification? You just said that the calcification is associated with high mortality, right? So can I, maybe it's better not to give calcium for bone health early on in chronic kidney disease. Yani patients stage 2, everything is fine with him. Calcium is normal. Should you give him calcium to protect the bone? No, do not do that. For stage 2 and stage 3, do not give calcium only for bone health. Do not give calcium, okay? Okay, how about that? Maybe, okay, calcium-based phosphate binders versus phosphate binders, other phosphate binders that are not based on calcium. Calcium carbonate versus sevelamer, for example. What do you think about that? In KDIGO, they said, we suggest restricting the dose of calcium-based phosphate binders. But again, it is 2B. And look at the, this statement. Some members of the work group felt that available evidence does not conclusively demonstrate that calcium-free agents are superior to calcium-based agents. This is in 2017. In 2019, 2 years after the guidelines, there were a published study, retrospective study of good number of patients. They looked at those patients who are 65 and older who have used calcium-based binders and those who haven't used calcium-based phosphate binders. And in 6 months' time, they did not find any difference between them when it comes to cardiovascular mortality. So are we gonna avoid calcium-based binders? Well, you may consider that for young patients, for example, especially, those patients who are 18, 19, 20, 25-year-old. Maybe you may consider that in order to decrease the burden of calcification. Maybe, okay, but if someone can, but I can't stand in any argument saying, no, I will not do that. I will still give calcium-based phosphate binders. Why? Because I don't have evidence yet to indicate otherwise. Okay. What is the implication of dysregulation of FGF23 and Clotho axis? We said it's associated with cardiovascular mortality. We said it's lead to hypertension and LVH, and it may cause uremic cardiomyopathy. So why not to target this axis? Well, they are looking into it right now. One of the approaches now is to prevent the rise of FGF23 in chronic kidney disease. Maybe that will work if you just target it as a therapeutic focus. How? Maybe by inventing or discovering an antibodies, monoclonal antibodies against anti-FGF23. Good idea, but tested only in animals, not yet in human. Or maybe administrating Clotho that will probably enhance the native Clotho and improve the affinity of FGF23 and will lead to phosphaturia. Good, sounds good, but yet we don't have researches on human beings. Okay, other clinical implication, yes, the low calcium sensing receptors. If you have low calcium sensing receptors, not much expression of calcium sensing receptors on the parathyroid gland, what to do? To decrease the parathyroid hormone, give calcium mimetic agents. And from here, the idea of cinacalcet actually came. We have a study published in New England Journal of Medicine in 2004, very famous study that showed that giving cinacalcet will significantly reduce the parathyroid hormone. However, reducing the PTH, will it improve the survival? Hard question again. Well, the result of using cinacalcet in dialysis patients, the EVOLVE trial in 2011 showed that even if you decrease the PTH, actually there will be no difference in mortality between those patients who have received cinacalcet and those who haven't received cinacalcet over 5 years. Very disappointing. Yeah. Okay. One more implication. You said that the vitamin D receptors are actually not expressed very well on the parathyroid gland, and that may explain why sometimes we have resistant parathyroid hormone, despite of giving very high level of calcitriol or pericalcitol. Some of our dialysis patients on very high level of these vitamin D analogs, and yet PTH is significantly high. Why? Maybe one of the possibilities that would explain this finding is, well, you don't have vitamin D receptors that would sense the vitamin D that you're giving. Okay. So in summary, CKD is a state of hyperphosphatemia, high PTH, high FGF23, deficiency of Clotho, deficiency of 1,25-hydroxyvitamin D. Cardiovascular mortality, unfortunately, remains very high in chronic kidney disease population, despite of the medicines that we are trying to, introduce in the last 30 years. Cardiovascular mortality did not change much, to be honest. Hyperphosphatemia and dysregulation of the Clotho FGF23 axis represent the main therapeutic focus nowadays. There are important gaps, I have to admit, and every nephrologist knows this truth. There are actually important gaps in our knowledge and understanding of mineral-borne disorders in chronic kidney disease. We know that high phosphorus will lead to mortality, but we're not able yet to show that lowering phosphorus will improve survival. We know that high PTH is associated with mortality, but we failed to show that lowering PTH will improve the survival, and so on. So it's quite complex topic. There are several and important gaps in our understanding. I hope in the near future we able to identify those gaps and get the appropriate treatment, inshallah. Thank you very much.
Thank you, Dr. Muhammad, and it was a very good effort from you in those two presentations. We have some questions here. Which comes first, high phosphorus or high FGF23 or PTH in CKD?
Yeah, it's a very good question, actually. It was one of the title of one of the articles, which one comes first, phosphate or PTH? Hard to say, to be honest. They believe that the FGF23 will first start to go up, followed by phosphorus, followed by PTH. Okay. But this is not, this is not a fact. Okay, this is not a fact. All right, we think that this is the case.
Okay.
But in any way, all these things actually get affected early on. Sorry, not the sorry. Did you say phosphorus? I'm talking about FGF and PTH.
Yes, and also phosphorus.
Sorry. Yeah, let me rephrase it again. Phosphorus. Sorry, let me rephrase it again. The question about FGF and PTH, which one comes first? Hard to answer. But maybe FGF23 start to decrease at somewhat higher level of GFR in comparison with PTH, but both usually decreases early on. Okay, phosphorus, it's late. Okay, you might have initial rise that provokes FGF23 and PTH, but FGF23 and PTH will be able to get the phosphorus within the normal range until GFR drops below than 30, when phosphate start to go up again.
Okay, thank you. Does cinacalcet or vitamin D analog affects vascular calcification?
I'm not aware that cinacalcet is associated with increasing risk of calcification, to be honest. But vitamin D, as we all know, will increase the absorption of phosphorus from the gut, right? And if you increase the absorption of the phosphorus from the gut, you will contribute to increasing the phosphate level, right? And phosphate level is one of the factors that would enhance and provoke calcification. Okay.
I think the question means if there is already the patient suffering from vascular calcification, if I will give him cinacalcet or vitamin D analog, does this halt the progression of vascular calcification or even decrease it or not?
Sure. So I'll complete what I just said. So vitamin D basically will enhance the phosphate excretion, and if you enhance the phosphate excretion, you will increase the phosphate level. Right? And that may contribute to calcification. Having said that, vitamin D also will suppress the parathyroid hormone. Parathyroid hormone is known to cause bone resorption and mobilizing the phosphorus from the bone. Okay, so I could say yes and I could say no by explaining two different mechanisms, and that's why this talk is complex, to be honest. So vitamin D, if we are able to not to increase the phosphorus level by giving vitamin D, and at the same time we're able to decrease the parathyroid hormone, I think that will be helpful. However, if we are good in decreasing the parathyroid hormone, but phosphorus became out of control, I think that's not good. Okay? So it might be good if you're still able to control the two arms, the phosphorus as well as the PTH.
Okay.
Giving vitamin D, suppressing the PTH, but not increasing the phosphorus absorption to the point that it affects the phosphorus level.
Oh, okay. In case of vascular calcification, again, using statins like Lipitor or Repatha can decrease the calcification?
I'm not aware of any study that say so, to be honest. calcification, I know that the having high phosphorus and having calcification will increase the atherosclerotic plaque. We all know that, absolutely. That's why in chronic kidney disease we recommend to give statin. Okay.
Yes.
However, in dialysis population, okay, if you initiate the patient on statin, that would not affect the mortality,
Exactly.
cardiovascular
Yes.
mortality. So why we have a contradicting kind of views, right? I have no good answers for that, and that's because of the complexity of the disease.
Yes, yes. We know that we have to keep the lipid profile in the best values in CKD, but once the patient went into dialysis, we don't have a consensus regarding using statins or not. But what we do, if the patient started dialysis while he is on statin, we let him go on his medication, but we don't initiate. We do not.
But we don't initiate because initiation did not show that it improves the cardiovascular risk.
Okay. Thank you, Dr. Muhammad, and inshallah, you will keep supporting us as you promised in the next years in our webinars. You are one of the figures we are proud to have in our webinar. Thank you.
الله يسلمك. شكرا جزيلا على الدعوة الكريمة.
أستأذنك, can we stop sharing the screen?
I will. في أمان الله.
شكرا. And now we will move to next session. Next session, we will start with hematology subspecialty, and we are proud to have Dr. Abdulaziz Al Abdelali, consultant hematology and associate professor in King Saud University. Dr. Abdulaziz will talk to us today about a very important subject, which is heparin-induced thrombocytopenia.
Okay.
Okay, yes.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Dr. Nasser, and for the invitation. And I hope that this presentation would be helpful for all our physicians. Heparin-induced thrombocytopenia, how we can approach it. Let's not go to next. Okay, so at the end of the presentation, we should be all able to have a clear definition of heparin-induced thrombocytopenia, also an idea about the incidence and how significant it is. We should be able to have a clear approach to this disorder, and hopefully, which is most important actually in the presentation for all our physicians, is to understand a measure to decrease the incidence of heparin-induced thrombocytopenia, which we'll talk about it. Also, a measure to screen for this disorder earlier, at the early presentation before thrombosis happen and mortality, morbidity happen. Then an approach to the diagnosis and how to treat it. Let's just clear some terminology of this disorder. There are generally two types of HET or heparin-induced thrombocytopenia. Previously, it's called type 1 and type 2. Type 1, which is the one below, is non-immune, it's very benign, it's delusional, rarely platelets go below 100, and it's not an antibody-dependent disorder. You shouldn't worry about it. Continue your heparin the platelet recovery. The serious disorder is actually an antibody dependent, which is type 2 or heparin-induced thrombocytopenia. And if it is with thrombosis, they call it HITT, heparin-induced thrombocytopenia with thrombosis. This table shows the differences between the two types, which I just mentioned. Type 1, the benign one, is very common, 10 to 30%. It's non-immune. It can happen from day 1 to 4, as opposed to day 4 to 16 of the type 2. No antibody, it's not immunological, it's delusional, as opposed to the antibody immunological based type 2. No thrombosis, it's very benign. Type 2 is the one which is associated with thrombosis, morbidity, and mortality. Just observe type 1 and it will resolve. With type 2, an action needs to be done, mostly stopping all heparins and replacing with non-heparins. Now, the definition of type 2 or heparin-induced thrombocytopenia thrombosis, it's a life-threatening prothrombotic thrombocytopenia. It's a paradox. After exposure to heparin, due to the formation of IgG antibodies that interact with platelet factor 4 and heparin complexes. This leads to massive platelet activation, consumption, endothelial cell injury, increased thrombin generation, and thrombosis. Not to forget the other side effects of heparin in the acronym BOAT, which is bleeding, osteoporosis, alopecia, and thrombosis. The incidence of this type of head is about 0.5 to 5%, but this depends on lots of factors. One of them is the duration of therapy. The more the patient is on heparin, the more likely he will or she will develop this disorder. Type of heparin. The unfractionated heparins induce more head than low molecular weight heparin or pendaparinol, which is Arextra. The dose. Manifesting head, it's associated more with the therapeutic more than the prophylactic or flushes. While for immunization, prophylaxis, because it is intermittent exposure, leads to more immunizing effect than the therapeutic. Recent exposure to heparin within the last 100 days. Type of patients, generally speaking, patients where there is vascular integrity is disturbed, they are more likely to have head vascular patients, cardiovascular patients, orthopedic, more than the medical or obstetrics. For unknown reasons, females are more likely to develop this disorder. And generally speaking, patients are categorized into high, intermediate, or low risk for developing heads, with 1% to less than 0.1%, as shown in the chart here. The high risk ones are the surgical patients, ortho, cardiovascular, or receiving prophylactic or treatment doses more than 4 days. The low risk are the medical or obstetric patients receiving low molecular weight heparins more than 4 days, or heparin flushes. Now you can access such table from so many apps in your phone and your iPhones, which is a very good resource that everyone need to with handy. See these patients, and I will mention that later on. Now, what's the issue with this head or heparin induced thrombocytopenia, or the consequences? Why we need to look for it and treat it? It's associated with venous thrombosis in 70%. It's very high prothrombotic, whether it is deep vein or pulmonary embolism, limb gangrene, cerebral sinus, Also, it is associated with arterial thrombosis. Other complications that you need to look for: adrenal hemorrhagic infarction, heparin-induced skin lesion at injection site, a syndrome or reaction called acute systemic reaction to IV heparin boluses, which manifests within 5 to 30 minutes after a bolus heparin, with fever, chills, tachycardia, hypertension, flushing, headache, chest pain, dyspnea, nausea, vomiting, large volume diarrhea. It's a sudden anaphylactoid reaction that leads to death. Together, surprisingly, it is associated with transient global amnesia. This is an acute systemic reaction to heparin in a patient who is sensitized and having the antibody. How can we decrease the incidence of HET, or can we do that? And the answer is yes. And this is one of the most important messages of the presentation to all our juniors, residents, registrars, specialists in all specialties. This is an action done in 2007 to 2012, where they call it avoid heparin program, and it should be called avoid unfractionated heparin program, where you can replace it with low molecular weight heparin as much as possible. With that, they managed to decrease suspected HET by 42%. All these numbers are with significant p-value. Positive HET assay decreased by 63%. HET decreased by 79%. And HET-associated thrombosis decreased by 91%. This is a great difference that simply we can do it overnight for all our patients. Now, the next message from the presentation is, can we screen for these disorders in order to pick the platelet drop earlier, before it becomes severe, before the patient starts manifesting thrombosis? And the answer is yes. And this is the ACCP, or American College of Chest Physicians, recommendations, where they divided patients in high risk, intermediate risk, or low risk, as previously we defined there, whether they are on heparin or low molecular unfractionated one, or low molecular weight heparin or fendaparinol. Fendaparinol or Arextra, you don't need to follow the platelets. It's rarely you will see HET with it, if any. They mention no need to do a baseline, but you need to do a baseline platelet, not for HET, but any patients going for anticoagulation, you need to know where the platelet count is. So those with the unfractionated heparin, you need to, as baseline, and repeat within 24 hours, then every 2 to 3 days, from day 4 to 14. This is the time where HET happened. In the prophylactic situation, every other day, the same duration. Now, if there are flushes, they said that there are no recommendations, or therapeutic low molecular weight heparin, or prophylactic low molecular weight heparin in the high-risk group. But to be on the safe side and the ease of application, myself, I do it like the intermediate one, every 2 to 3 days, from day 4 to 14. Now, once you are faced with a possible HET, i.e. a patient with thrombocytopenia, heparin, the first step is really to see the probability of the patient having HET. Is it low, or intermediate, or high? And this table, you will find it also on the so many apps over your iPhone for ease of application and calculation. And simply, it is 4 T's: thrombocytopenia, timing of onset of platelet count fall, thrombosis, other causes for thrombocytopenia. For the thrombocytopenia, it's always what we look for is a fall greater than 50%. And the platelet nadir should not be less than 20. If it is so, you score 2. Rarely you see platelet count less than 10 or 20 in HET. You can have it, but it's rare. So by applying this scoring system, you will get points from 0 to 3, your probability. It means that HET chance is less than 1%. It has a very high negative predictive value, 99%. This means that you can exclude HET, you can continue the heparin infusion without worrying. But if you're having intermediate probability or high probability, there is certain actions that you should do, which we will come to. Before we try to treat our patient, there are certain points that we should avoid. These things are very harmful to the patient. One may say, just subheparin and it will go away. Well, that's not true. Or just switch to low molecular weight heparin because the chance of HET is less. That's also not true. It's very risky. Just make it prophylactic dose because a prophylactic dose is less in amount than a full anticoagulation. That's also not true or not right. Fourth option is try to get this INR quickly with warfarin, give them 10 or 15 or start with 5 even, so that I can avoid the heparins. That is very dangerous. Last but not the least, one may think, well, this couldn't be HET because the platelets may be still within the normal range, but they're not as the baseline, or maybe they are 10 or 20. Now this is the first point where just stop the heparin and do nothing. This is the chance of thrombosis in patients who developed HET, and heparin is stopped, but no anticoagulation is given. 52% will have thrombosis in the next 28 days. So they must be covered with another non-heparin anticoagulant. This is a skin reaction after low molecular weight heparin injections in a patient who developed it. So still they do develop HET, they develop a reaction. The antibodies, they interact with low molecular weight heparin. Now, this is a case where on the left, changing the dose from a full treatment dose to a prophylactic dose with subcut still develops skin injection site necrosis. On the right side, this presentation is very, very significant. This is induced by giving warfarin early while the platelets are not recovered. And the reason for that is that warfarin will decrease potency and S before its anticoagulant effect starts. So that by itself is a highly prothrombotic situation, and then it leads to skin necrosis. And usually one of the recommendations in treating these patients with a non-heparin, if the INR initial is high, giving vitamin K to correct it is advisable. Now, this graph shows the distribution of the platelet count in patients with HET. And just the short point is, you see that 10% of the patients, they have a platelet count more than 100. So I can't say that that patient, his thrombocytopenia is not severe, so it's not hit. No, it can be hit. At the same time, other 10%, they would have a platelet count less than 20. So keep this in mind. Now, what to do? There was I'm sorry, on the left, there was a chart, the flow chart, how to approach this disorder. It's not there, but in short, no. In short, as per the 40s, if your 40s is low, then you don't need to worry. Don't send samples to the lab. Continue your heparin. Your patient should be okay. Now, if his score is intermediate or high, then must stop any heparin, literally any heparin. And I want to emphasize on this, which we always see it in the clinical side. When you ask them, you need to speak with the nurse. Ask the nurses, no heparin. They say, okay, no heparin, no IV, no subcut. But you find the patient having heparin flushes, heparin locks, heparin in the TPN sometimes, heparin-coated Swan-Ganz catheters. So literally no heparin. And this should be discussed with the treating nurse so that she can or he can avoid all these. So the first step that we need to discontinue all the heparins. Never switch to a low molecular weight heparin or warfarin. Must start a non-heparin anticoagulant, and I'll come to that, the choices. We should avoid platelet transfusion unless bleeding. If you give platelet, with this interaction is having more thrombosis will happen. If the INR is high, need to be reversed by FFP or vitamin K. Send a sample for say it's ELISA. We need to communicate very well with the everyone taking care of the patient about this reaction. And we list this as a significant allergy. We label the patient, the arm, the bedside, all IV sites. We never, number 5 is coming later to it, which is non-heparin's anticoagulant. You may, preferably, must consider asking a hematologist to have a look at your patient. Monitor the patient closely for signs and symptoms of thrombosis and bleeding. Again, never ever use warfarin to expedite increasing the INR until the platelet count has recovered to more than 150. Try to do duplex ultrasound to investigate for upper and lower limb DVT. And if your patient is having chest respiratory symptoms, need to rule out BE. Now, how again to approach it? From medication point of view or non-heparin management. If the patient, generally, if they are unstable, it's not advisable to give Arextra. It's associated with higher mortality. So we preserve Arextra or Fundaberenio to someone who is stable. So let's see the patient who is stable. We look first at the renal function, then at the hepatic function. Now, if the renal function is okay, go ahead with Arextra. It's far much simpler drug than the other non-heparinoid. But if he's having or she's having renal impairment, creatinine less than 30, then look at the liver. If there is liver impairment, the choices will be argatropan or bivalirudin or danaparoid. Okay, if there is liver impairment, then the choices are bivalirudin or danaparoid, not argatropan. I know it's very difficult to get these medications in any pharmacy, so this is one of the most difficult encounters with this disorders, actually, having the availability of these medications. Now, which of all these anticoagulants, this is the dosing and how to monitor them. Now, argatroban, rivaroxaban, followed by ABTT. It's not difficult. Danaboroid also, but mind you, the lab should have a danaboroid specific anti-10A assays in order to measure it, not the usual ABTT, which is most of the time it's not there. These medications, the above three, they need to be given as a bolus, then continuous infusion with titration. So definitely as an inpatient. Fundabarinio or Arextra, subcutaneous, can given as an outpatient. Doesn't need for monitoring as long as it's given as per weight. Now, apixaban or Eliquis, dabigatran or rivaroxaban, these are one of the new drugs, direct oral anticoagulants. They are tablets, so it's very easy to use them, but mind you, none of them is FDA approved. So this again slide, I don't know what's happening with my computer. Anyhow, how to select among these anticoagulants. Always think of it according to your patient's clinical scenario. There is a patient who is extremely sick, and you may intervene surgically or vascularly. So you need something that really short-acting medication. One of the things is rivaroxaban is one of the examples for that. You may have a patient who is stable, so you don't need to keep monitoring the level. You want an ease of administration. Arextra or fundabarinio is an option. Third situation is where your patient is again stable. You're not going to monitor, and you want an oral tablet. The drugs are suitable for that. One thing about drugs is that sick patients with massive thrombosis, these patients are really not included in any of probably of the reports of drugs in the setup. So sick patients with thrombosis, significant thrombosis, clinical thrombosis, it's advisable to avoid drugs in them. Now, in summary, for HET or heparin thrombocytopenia, induced thrombocytopenia, the main points of this presentation, which you can make a difference for your patient, is that HET is a preventable serious thrombotic disorder. Just try your best to replace unfractionated heparin with low molecular weight heparin as much as you can. Adopt screening. It's a very simple, cheap, and allows early intervention, decreasing morbidity and mortality. It's a simple CBC testing. Always apply the 4T's pretest probability whenever you see thrombocytopenia, and accordingly act. Be aware, please, of the list of the do not do that we mentioned about. Then follow the recommended action for patients with score more than or equal to 4, which is also we mentioned in one slide. Then choose an alternative non-heparin anticoagulant based on patient clinical factors. Thank you.
Thank you, Dr. Abdelaziz. And now we will go for the questions. How to monitor drugs?
Okay, drugs. Usually drugs are one of the major advantages of them is that they are given in a fixed dose without the need for frequent monitoring in a normal situation. In patients, either prophylaxis or treatment, atrial fibrillation, DVT, BE, without major comorbidities. Now, you must adjust them based to the patient renal function. They should be avoidable in patients with severe liver disease. Please make sure that you check the interaction with other medications. Use your iPhone, okay? It's used, or Samsung, whatever. One of the initial thought advantages of drugs is that you don't need to monitor, no interaction. And that is not true, actually. There are major interactions with medications. Antimicrobials, cardiac medications, where most of the patients are on. And new reports are coming. So that's why I say keep checking on your mobile because it is updated for every medication you're going to start or the patient is on these medication that drugs. Simply because we don't monitor, we don't test for them. So if there is an, it's not like warfarin. Warfarin is very simple. We just use warfarin and we know where are we. There are, however, laboratory tests specific for the drugs. You will not find them and everywhere, including here in Riyadh. I think in Faisal they do it. But from a clinical, practical point of view, I don't think that you will be able to request them, or if you request them, they will not come in a timely manner. So please, whenever your patient is not in the category of the clinical trials that use drug, try not to use it. Myself, I have extreme cautions about them.
Okay, thank you, Dr. Abdelaziz. And now we have time for a presentation I prepared for you. It is not about a new medicine. It is not about a new study. It is not about a disease. It is about a way of thinking. Since long time, since Sayyidina Adam and Sayyidina Qabil, it is a way of thinking. Sayyidina Qabil learned from the crow how to bury the dead body. And also we learn how to fly from the bird. So we always learn from nature. We learn from the animals. So let's see here together what I will present now. And I hope this presentation will be enjoyable for all of us. Kidney biomimicry. It is a strange title, and I chose it as a very nice presentation, light in between all these presentations talking about diseases and drugs. Let's see what this title means. Most studies on kidney disease have relied on classical experimental studies in mice and rats and others, maybe guinea pig, and clinical studies also in humans. And from such studies, much understanding of the pathophysiology, physiology of the kidney disease have been obtained, and the breakthrough in prevention and the treatment of kidney disease have been relatively few, and only new approaches to fight the kidney disease are needed. So if we will think about chronic kidney disease, we are always working on how to do the conservative management. And only the breakthrough has been observed with maybe SGLT2 inhibitors. The prevalence of kidney disease or chronic kidney disease is a pandemic or epidemic. About 10% of the worldwide general population shows some signs of kidney dysfunction. And CKD is a global health problem. So let's go back. How do we learn from animals? And what is the term biomimicry? The science that studies nature's model and then imitates or takes inspiration from these designs and the process to solve human problems. One of the earliest examples, as I mentioned before, is Abbas ibn Firnas. He learned how to fly from the birds. So how will we learn in the kidney disease from the animals? Do you know the bear, al-Dubb al-Qutbi? It is very nice, and all of us may have a toy or a puppet like the dub or the bear. But did we think about this bear when he hibernated for 4 to 6 months? Did any one of us think why he's not suffering from bed sores? Okay, we may answer this. He is changing his position every 2 to 4 hours. Okay, let's think together again as doctors. This bear, why he's not suffering from muscle wasting like people with long-term care and they are bedridden, and because of the bad nutrition they have muscle wasting and protein catabolic state. Why this muscular bear doesn't suffer from this? And if we will know his secret, we may learn how to deal with high urea and high creatinine. Actually, this bear is sleeping for 4 to 6 months. Do you think he's urinating on himself? No bed sores, no urination, no food, and he's still muscular and healthy. Let's see what is his secret. Here, we discuss the kidney biomimicry as a new approach of understanding the kidney disease. Examples are given on how various animals have developed a model or a way to prevent the kidney failure or to deal with hypoxia and oxidative stress from complications of hyperglycemia. You see, this bear is sleeping for 4 to 6 months and he has renal failure. I will show you studies, but without any signs of azotemia. And this is a vet doctor who is running from the bear after he tried to take a urine sample or a blood sample. Many bears will hibernate for 4 to 6 months each winter, during which time they will be anuric. 4 to 6 months without urine, according to our assessment for the humans, he has renal failure. And when we took blood samples from him, we found that his GFR is only 25% of the normal. Minimal urine, doubling of serum creatinine. Serum creatinine rises during hibernation, consistent with reduction in GFR and anuria. But interestingly, urea is not rising, and it is not stable. It is down. It is half. It is half the level in comparison with the doubled creatinine. In this recent study performed in 16 free-ranging bears from central Sweden, it was found that whereas serum creatinine is doubled, serum urea is going down during winter and hibernation. So we have 3 questions. Where is the urine? Why creatinine is doubled? And why urea is halved? And if we will say that after this hibernation for 4 to 6 months, he is healthy, how we as a human, how can we do like him and deal with the high creatinine and muscle catabolic state? These are the 3 questions. It is about recycling of urea, which is not here in the human. Let's see what is going on in this bear. The fall in serum urea reflects several processes, including a decrease in the production due to his fasting. Urea is not getting high because he's not eating. However, most important feature is the recycling of urea back to protein. He's catabolizing and metabolizing the urea into amino acid. So the urea itself becomes a nutrient. If we will work on this and we know his secret, we may deal with chronic kidney disease where we suffer from high urea. If this urea will be converted in a human to amino acid, you see, no one will do dialysis. The current primary hypothesis is that urea is recycled due to its secretion into the intestinal lumen. And there is a bacteria inside this lumen that catabolizes the urea back to a protein. A consequence of urea recycling is preservation of protein. And as you see, this is the urea cycle from urea bowl to hydrolysis to going to intestine, then making amino acids again and build up the body protein during his hibernation. And this bear is not suffering from hypercatabolic state or muscle wasting. He's only losing 10 to 15% of his muscle protein during hibernation, resulting in very minimal skeletal muscle atrophy. But what is the trigger? The trigger lies behind his nutrition just before hibernation. And if we will see what is in this nutrition and what is the substance in this nutrition that turn on the urea recycling, we may benefit in humans. This unique ability of bears to recycle urea during hibernation is not observed in other hibernating animals such as the hedgehogs and the ground squirrel. In bears, this mechanism is likely turned on at a time point before hibernation, but yet undefined trigger till now. That could include changes in bear diet, temperatures, hour of the day. Nelson et al. Reported that urea level started to decrease in autumn prior to entering his hibernation, suggesting that changes in the bear diet may contribute to this metabolic switch. The typical diet of the bear during late summer and the autumn include enormous amount of berries. Do you think if I will ask my chronic kidney disease patients to eat berries, they may have the urea recycling? It is not that easy, of course. These berries from the vaccinum family, such as lingonberries and the huckleberries and the bilberries. As berries contain some little protein, the need to synthesize and excrete urea diminishes. Moreover, as berries contain this substance, resveratrol, which recently were reported to regulate the urea cycle via deacylation of the carbamyl phosphate synthetase, have a pivotal role in ammonia detoxification. It should dietary shift from summer to autumn in bear affect serotonin activity. Fruits also contain fructose that generates uric acid during its metabolism. And uric acid also has been found to inhibit enzyme involved in urea synthesis. So this is the secret of the bear. But why the creatinine is doubled? There is another secret in this bear. The bear bladder becomes leaky during hibernation. That's why he's not urinating on himself and he's anuric. During hibernation, again, allowing reabsorption of urea, not only urea, but he's also preserving the amount of fluid in his body. Allowing reabsorption of urea, where this urea will go to the intestine, where it will be recycled into amino acid to be reabsorbed and to build up protein again and minimize the muscle wasting. This is the future research in human. If we can determine what triggers the changes in urinary bladder urea transport during hibernation and the composition of the intestinal microbiota in hibernation compared to the active summer state, nephrologists might better understand how bears can prevent azotemia despite reduced renal function, and this will help us in managing chronic kidney disease. We will take a break for a minute. Okay, let's learn another lesson from another animal. How to prevent kidney injury, coping with ischemia. We all know that as a nephrologist, I may have a consultation that this patient have been bleeding and he is shocked and his kidney suffered from ischemia. That's why he has acute renal failure. This is one of the most common. Pre-renal, ATN, acute cortical necrosis, ischemia for the kidney, and poor flow and poor renal blood flow. This will go, will make our patient suffer from acute kidney injury. You see this nice animal? This is the elephant seal, or al-fukma. This animal, we will learn a lesson from him now. One of the most common consultations that nephrologists receive is a consultation about how to manage acute kidney injury secondary to ischemia, such as following an episode of hypotension or major surgery and bleeding, as I stated before. Prolonged ischemia of the donor kidney while we're doing transportation of the donor kidney to the transplant theater. Delayed graft function and acute kidney injury may suffer from. The pathogenesis of acute renal injury is complex, but thought to relate to oxidative stress and inflammation. And it is at the end, poor renal blood flow. And then when reperfusion will happen, what will happen? We may suffer from ischemia reperfusion syndrome. Ischemia reperfusion syndrome, that even after I resume the renal blood flow, I may suffer from a problem from the oxidative stress and the inflammations that happen. But interestingly, this animal, we will learn a lesson from him, from Allah, of course. Interestingly, some animals have developed these ways to protect themselves from this type of kidney damage. This elephant seal or al-fukma have developed an extraordinary ability to survive prolonged asphyxia. When I was attending this workshop, it was in Hungary, in Budapest, they told us that this animal have zero renal blood flow. And at the end, when reperfusion will come, he will not suffer from reperfusion injury. That's the one we are suffering from as human when we have this acute kidney injury secondary to acute tubular necrosis. So what they do, they have underwater dive. This elephant seal can descend up to amazing 2 kilometers during a dive for a period. For periods that can extend up to 100 minutes per dive, 100 minutes with zero renal blood flow. The diving lifestyle of the seals require extreme cardiovascular adjustment to maintain sufficient oxygenated blood to his heart and the brain. This is the most important. And to help reduce the oxygen demand, seals will reduce their heart rate, cardiac output, and reduce their blood supply via vasoconstriction of several organs, including the kidney. Brown et al. Obtained angiogram. He made an angiogram for the harbor seal and demonstrates that the constriction in small arteries, arterial branches is so intense that blood flow is essentially lost in muscles, skin, kidney, liver, spleen for 100 minutes. And even though they are not suffering from acute kidney injury. Kidneys are subjected to prolonged vasoconstriction during dive, with complete cessation of renal function, which is followed by reperfusion after each episode of diving. And his inulin clearance have been measured to decrease 90% during the diving. That lasts longer than seal's aerobic dive limit. Halasaz et al. Studied isolated perfused kidneys from both dogs and seals. He brings the dogs and seal to see the difference, and subjected both of them to 60 minutes of ischemia at 35 degrees. In contrast to the massive urine flow during recovery of the seal kidneys from dogs didn't produce urine at all. Thus, the seal kidney is unusually tolerant to ischemia and ischemic acute kidney injury. And this is the secret we need to know, like we knew the secret of the bear. It is likely that several mechanisms are operative to help to protect the seal kidney from ischemic injury. First, the kidney of the seal may be better adapted to anaerobic metabolism, as levels of glycolytic enzymes are generally higher. In the seal kidney compared to adult dog, seals also show an increased ability for aerobic fat-based metabolism during hypoxia associated with routine diving. One of the products of fat metabolism also is beta-hydroxybutyrate, which may help to protect against ischemic injury. by providing an energy fuel that releases glucose. This is very important because while transporting the donor kidney to the recipient, we may get benefit from this mechanism to prevent the ischemic reperfusion injury. Ischemia reperfusion in these animals is also associated with increased production of reactive oxygen species. Not surprisingly, seals have developed an outstanding antioxidant defense against ischemia reperfusion injury, and their kidneys have higher level of glutathione disulfide reductase and glucose 6-phosphate dehydrogenase and total glutathione levels compared to the pig kidney or human kidney. So working on this antioxidant is the key behind helping these seals to guard against ischemia and also reperfusion injury. And they found that there is something behind this in the fasting. These seals, the antioxidant system may be stimulated by prolonged 1 to 3 months fasting phenomena. That is also observed in seals as oxidative stress tend to increase in food deprivation in these species. Fasting, did you hear me? Fasting. So if we are fasting Ramadan, does this increase our ability for having antioxidant materials in our body? Maybe. Maybe fasting in Ramadan maybe increase this ability, and we may have less ischemia reperfusion injury. But we have to study this more. One might posit that upregulation of the antioxidant system with fasting is an adaptive response that provides protection during diving for food. Recently, fasting has been found to stimulate NRF2 activity in vivo and SIRT1 dependent mechanism in both mouse and human. Thus, future studies of the mechanism regulating the antioxidant system with fasting and diving in the seal could potentially provide insight as to how to prevent ischemia and ischemic renal injury in humans. I will stop here. I just gave you a break, refreshing break. Again, it is about something interesting, and I hope all of you enjoyed this small presentation. I still have 2 more animals. If I will have time, I will give you an insight about them. Thanks for all. And now we will go to Dr. Muhammad Ibrahim. Dr. Muhammad Ibrahim is a consultant hematologist, and today he will talk about TTP or thrombotic thrombocytopenic beriberi. Thanks for all.
Our talking today will be on thrombotic thrombocytopenic beriberi. It is one of microangiopathic or thrombotic microangiopathy. Definition of thrombotic microangiopathy is a pathological term for condition characterized by microvascular change, including thrombosis associated with laboratory abnormalities of microangiopathic hemolytic anemia and thrombocytopenia. Classification can be classified as classical hemolytic uremic syndrome, atypical hemolytic uremic syndrome, and thrombotic thrombocytopenic beriberi. Atypical hemolytic uremic syndromes may be familial, sporadic, idiopathic, streptococcal pneumonia associated, cobalamin disorder, second and on sometimes secondary form like infection, autoimmune disorders, drug, pregnancy, postpartum, and HELLP syndrome, and other. Thrombotic thrombocytopenic purpura may be congenital, idiopathic, secondary form like infection, autoimmune disorder, drug, pregnancy, postpartum, HELLP syndrome, and others. Other microangiopathy, thrombotic microangiopathy, glomeruloneuropathy, malignant hypertension, malignancy, solid organ transplantation, scleroderma renal crisis, radiation nephropathy, and the high stem cell transplantation. Classification of hemolytic uremic syndrome, thrombotic thrombocytopenic purpura according to pathogenesis, type of hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura according to the specific causes, like infection-related Shiga toxin-producing E. coli or Shigella, pneumococcal infection, HIV, other viral infection, or bacterial infection. This is the typical form. Atypical form, including complement factor abnormality, like factor H deficiency and factor 1 deficiency, miscellaneous, like connective tissue disease, drugs, and malignancy. Thrombotic microangiopathies other than classic and atypical hemolytic uremic syndrome and TTP, including infection, systemic infection, immune deficiency virus infection, H1N1, influenza, salmonella, typhi, and others, autoimmune disease, SLE, antiphospholipid syndromes, drug like quinone, oral contraceptive, mitomycin C, pregnancy and postpartum, HELLP syndrome, malignant hypertension, malignant solid organ transplantation, scleroderma renal crisis, radiation nephropathy. The characteristic laboratory finding will find in the peripheral blood film helmet cell, quartz cell, and fragmented cell, what is called schistocyte in the peripheral blood, reticulocytosis, complex test is almost negative, leukocytosis common in early stage, platelets are decreased, serum lactic dehydrogenase level is very high, and concomitant reduction in the serum haptoglobulin, normal BT and EBTT. This is microangiopathic hemolytic anemia, mechanical fragmentation of erythrocyte during the flow through partially occluded and high shear small vessels lead to schistocyte, elevated LDH, and bilirubin. TTP, the clinical signs including fever, thrombocytopenia, neurological abnormalities, microangiopathic hemolytic anemia, and renal dysfunctions. TTP, rare disease with a reported incidence of 6 cases per million, peak incidence in the third decade of life, higher among female, African, American, and obese patients. The clinical features of TTP are similar to those of atypical hemolytic uremic syndrome and in the most cases. TTP, the clinical diagnosis of TTP required exclusion of other etiological causes like systemic infection or another cause of thrombotic microangiopathies. Since renal involvement in TTP is typical mild, the renal prognosis is good. Relationship between hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura occur among adults, affect central nervous system more than renal, exhibit less frequent and less severe involvement in the kidney, involve multiple organs, and has a poorer prognosis. This is one fact underlying the pathogenesis. Endothelial injury lead to complement, exposure of subendothelial surface with platelet activation and aggregation lead to thrombi, cellular proliferation in glomeruli and arterioles. Red cells hemolysis is caused by mechanical disruption in transmission fibrin mesh work of microcirculation. What is meant by thrombotic microangiopathy? Intramural platelet thrombosis lead to consumption of the platelet, lead to thrombocytopenia. Others lead to microangiopathic hemolytic anemia, lead to hemolysis, anemia, elevation of the LDH and bilirubin. What is the role of valvular factors in the body when the vessel entry is done and under high shear stress. Valvular factor is synthesized in the vascular endothelial cells and megakaryocyte. He will bind to factor 8. Also, it's bind to platelet service, glycoprotein, fibrillin collagen type 1 and type 3 in the vessel's wall. This leads to facilitate platelet aggregation and adhesion to common blood vessels. Here we have the 3 measurement. What is the mean by Adams 13? This is will show this is a platelet, van Willebrand factors, and Adams 13. This is van Willebrand factors will be combined to the platelet, and Adams 13 will cleavage this high multimeres. If it not activated or here there is an absence of Adams 13, the persistent valvular large multimeres will be reduced platelet microthrombi. Our treatment, the most important treatment in our cases is early initiating of plasma exchange. There is some rule of corticosteroid. In some resistant case, we can use rituximab and eculizumab, and in some rare, you can use combined rival and kidney transplant. Thank you.
Thank you, Dr. Muhammad Ibrahim, for this nice presentation. Let's check for the questions. Why no bleeding with very low platelet in TTP?
The consumption of coagulation is not very low. This is the consumption of coagulation. There's no bleeding, but bleeding can be happened in such cases like brain and like this. It is also patients susceptible to can have bleeding. That's one of the serious conditions in this case.
Okay. In systemic lupus with secondary TTP, do you do plasma exchange or not?
Plasma exchange is a life-saving condition for all cases of TTP. This is the first line and the most important line to manage such cases because it is the one of the most dangerous emergency cases in the hematology. So exchange transfusion is okay. Otherwise, we can, after this, we can do anything to control the disease itself, the underlying cause.
In secondary TMA with hypertension, do you do plasma exchange?
In secondary TTP?
TMA, thrombotic microangiopathy.
Should be done if it fulfills the criteria. We should do plasma exchange like this. TTP is a serious condition. Whatever primary or secondary, will not. Once we get a case of TTP, we're not waiting to search what is the cause. First should be this an emergency. Should be first fulfills all criteria of this TTP. Should be do plasma exchange as early as much.
Role of capillacy in TTP.
This may be eculizumab. This is something in resistant case. This is something like rituximab and
Eculizumab,
eculizumab, yes.
And anti-C5.
Okay, this is all coming after plasma exchange. You can use corticosteroid, you can use rituximab, and you can use this. This is in cases of resistant. This is the line one of the line of the treatment. If you have resistant to plasma exchange, you have resistant corticosteroid also can be given rituximab. So you can use this as one of the our choice in resistant case.
Okay. Thank you, Dr. Muhammad. I think we finished the questions. Thanks for joining us. And now we have a very interesting subject. For me, myself, if I will leave the whole conference and I choose to attend only one presentation, I will attend this presentation. This is by Professor Dr. Mushabbab al-Mufrih. It is about evidence-based practice. Any doctor who doesn't know what is evidence-based practice has to revise what he's studying and has to change his way in studying and know what is evidence-based practice. Dr. Mushabbab today will give us a brief about evidence-based practice. Evidence-based practice may have workshops, few days to learn about it, but because he mastered this specialty and this subject, he can give us a brief in 30 minutes, inshallah, about this. Dr. Mushabbab is a senior consultant in family physician, very nice specialty. He learned in UK, and he has many certificates and publication in his specialty, and we all like to hear from him. Thanks, Dr. Mushabbab, for joining us today. And you may introduce yourself and talk about this evidence practice.
Yes, this one. Okay. Thank you. It's okay. You have to go first. Yes, thank you. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jamia. First of all, I'd like to thank the Mr. Chairman and the organizing committee, the scientific committee, for having me tonight. It's a pleasure really to be with you and to share with you some of my knowledge. And I thought it is really essential nowadays. Of course, I know that you have heard about evidence-based medicine and implementation in the practice, and how much this is so essential nowadays. I will not go through history. When did it start? In the mid of the 90s. And it's gained its importance since then, even in teaching for the medical schools and also for postgraduate part of from the evaluation. Evidence-based practices means simply how to implement evidence-based medicine in your daily practice when you are seeing your patients, either treating them or either looking for diagnostic tools, even if you are treating sore throat. The problems that we need always to make a clinical decision about our patient, either therapeutic issue, diagnostic, or prognostic. And one of the big survey done in UK about that the inpatient, the doctor, he found himself about from 5 times for every patient he has a question, and about 2 times for every third outpatient. But always, because of shorten of the time, they give we get less than a third of this. Most of our information needs are not met because our textbooks are out of date, definitely. It is, and also it is disease oriented rather than patient oriented. The journal ranking, and we have a limited time to acquire new information. So we need to learn tools of the statistical tools, regarding and also the critical appraisal of papers and how to choose between them. To keep up to date, it's estimated to read 29 articles a day, 365 days a year, which is impossible. So when we have a problem or a question, inquiry about anything with a patient that it might be in the gray area, so we have to define the problem that we have, formulate a clinical question to be answered, search for high-ranked reputable journals, search for RCT, learn statistical tools, and apply the critical appraisal. The evidence-based medicine, it saves time, saves life, limits malpractice, shorten hospital stay, prevent non-calculated complications, and improve the outcome, and adds to equity when you are dealing with patients in the same. It is, as I said, saves life, money, and time. Serve effectiveness, aimed and desired result. Serve efficacy, capacity of a change or difference. Serve efficacy, time, money, effort. This is the hierarchy of the evidence-based. It's from the down one, the unfiltered, the background information and expert opinion, maybe studied with this in the textbook, and you go to the highest one, the meta-analysis and systematic review. Those are praised and filtered. And you go, for example, meta-analysis or systematic review through many engines, like one of them, and the famous Cochrane database, the PubMed, or Sinahi, or whatever. Those always, they are giving us information about patient-oriented evidence. The same, the excellent one, we said systematic review, meta-analysis, multi-center studies, appropriate and with visibility. The three main issues that we are using in daily basis of dealing with patient: therapeutic, diagnostic, and prognostic. Today, just I will give two examples about therapeutics because of the shortened period of time. Suppose this is a patient you have seen, 50-year-old, diabetic, an oral hypoglycemic agent, social smoker, BMI 27, not hypertensive, lifestyle sedentary, LDL 125 milligram per deciliter, and hemoglobin A1C 7.8. The question is, are you going to give this patient the statin, whatever, any type of a statin? Sometimes we discuss this with the patient, he himself may be confused too. Some doctors, he said, some doctors say yes, and others say no. My answer always to the patient that medicine is all about gray. Just simple line of white and other simple of black with clarity. The hypothesis, whether or not there will be effect, and the estimation, it's how much the effect might be. By the way, hypothesis and estimation, it is theory and by statistic that they actually discovered by gamblers, and at the end it is developed by epidemiologists, and they change a lot of medicine. So you do search, then you found this nice article with the exciting, promising, sound good, that might answer your question and clear, and very reputable medical journal, British Medical Journal. So you want to go through this journal. You cannot read it as a whole while you are busy. If you know your tools of critical appraisal, you can take the decision within 5 minutes only to give your patient the statin or not. So you see the article, that what you from your midline search, you found this. It's the benefit of statin in people without established cardiovascular disease, but with cardiovascular risk factors, meta-analysis of randomized controlled trial. So it is a meta-analysis. It is the highest in the hierarchy. So as we said, that the title sounds good. That might answer your question. Then you will go to statistic directly. It depends on where you want to go. Me, myself, I used to go to the result to see. So here I saw the result, and all of this for me. Actually, it is very famous, big studies like WISCOPS, FCAPS, FIXCAPS, Prosper, AllHeart, Ascot, and whatever it is. According to my question, so those with red arrow, it's gives some answer of my question regarding my patient. Because if we go to here with AllHeart, it is people with hypertension, moderate hypercholesterolemia, whatever it is. So this one, it's not going to give me answer, and this one not, the other one. So I found 5 that it might help me. While it's meta-analysis, what I want to say that I'm going to look to the statistical result of those 5 studies. To see the description and the patient who have been recruited in each study, you can see all randomized trial, double blind, number of participants, the patient, huge. The drug, they use all type of statin almost. The main age, it is within the age that I'm also looking for. Women and men variation the same with the other risk factor like smoker, obesity, and so on. Then I go to the result to check what the study that I'm selected. So here, this one on the left side, this is actually the odds ratio. The all-cause mortality, this is not my concern. My concern is here of coronary events. I want to see, I want to decrease major coronary events. I can see here my answer is answered by AFCAPS, TICS-CAPS, answered also by ASCOT-LL, also by HBS cards, and also by mega, but here even the total, it is give also if you combine them together, then it's give odds ratio points. So what is odds ratio? In meta-analysis, you will not find relative risk reduction and relative risk and number need to treat. They will not give you. They will give you just the odds, because you can calculate the number need to treat from the odds ratio. The odds ratio is defined as the ratio of the odds mean probability, of A in the presence of B, and the odds of A in the absence of B, or equivalently. It means that when the odds are 1, it means benefit, same of the no benefit. So in our case, the odds ratio is defined as the ratio of the odds of cardiovascular event in the presence of a statin and the odds, the probability of cardiovascular event in the absence of a statin. So in our patients that we found the odds is about 0.5. It means that the statin is 2 times safer, safer than placebo, simple words. The relative risk or the risk ratio that we are going to see it in the second example is the ratio of risk of event in one group, example exposed, versus the risk of the event in the non-exposed. They are not alternating each other of the definition. We can see it from this example. A relative risk or odds ratio greater than 1 indicates an exposure to be harmful. So we will see it now. While a value less than 1 indicates a protective effect. This means in our meta-analysis that we saw that odds is about 0.5, sometimes 0.6, which means it's protective. It's better. It's good to give your patient diabetic with that age statin. I remember with the long time when they were lagging behind the giving statin, they said, don't let your patient die without testing statin. Last week, I have reviewed one actually editorial from the American Cardiology, and they found that even the doctors, they are not following the guidelines, while even there is guidelines. For clear cases, 1/3 of doctors that they are prescribing statin. So relative risk, if it is 1.2, it means that it means exposed people are 20% more likely to be diseased. If relative risk is 0.5, we should calculate relative risk reduction, so it will be 50%. So it means that the relative risk reduction is 50%. The odds ratio, when it is 1.2, means that the odds of disease is 20% higher in exposed people. Here it's give us the probability and the proportion of the group of people. Here in relative risk, it means the relative risk also in the group of people, but the relative risk, it means per individual. The value, the bar value under risk, it's not the visual assistant referee, but it is the value under risk. Sometimes it is using with the relative risk or the risk ratio, actually to determine strategies of loss prevention, or to determine how much you want to, you might lose, or you might want to prevent loss over years. So again, the question now, what do you advise me? Shall I prescribe statin for my patient? We said that we can calculate the number need to treat, but it's very, very big equation from the odds ratio. So when I calculate it, you need to treat 11 patients to save one's life with a total cost of 4,800 Saudi riyal per year. I think it's very cost effective by itself. Okay, so other type of randomized control trials, it you will find it in beta analysis. It is the original paper. You will find they will mention about relative risk reduction, absolute risk reduction, and number needed to treat. Let us see here. This is a summarized commentary of a well-designed randomized controlled trial using aspirin in adult with particular risk of cerebrovascular event. Found that 20% of the control group developed TIA or stroke, compared with only 12% of those receiving aspirin. So how can I just give aspirin for those patients with this shortened note or commentary? Would you agree to give aspirin to your patient as a prophylactic measure because of this, without knowing more? But it is effect meaningful. Just give without knowing the statistic. We will see. We will determine this now. We will turn this statement to statistics, and we will see. So we should plot a 2x2 table. We can put the disease that we are looking for, stroke and aspirin status. We found that patient who develop stroke and an aspirin 12, while those not receiving aspirin develop stroke 20, and the table is completed. Here we can replot it again, just to because always we put the table A, B, C, D. A, it is the event in the interventional, and IN, it is none in the terminal, no event, and the control, the events, the stroke itself, and control, and the control without no event. So we want to calculate the relative risk. It's really big equation. You can no need to memorize it, but just to know that there is something called relative risk reduction, that we have give the definition of that one, and you can go to the web wherever you want and just to take the question and calculate it at that time, then forget it. Plus, there's sometimes scientific calculator that it might help. The odds ratio. Then we want to calculate the relative risk. Calculation of relative risk is very simple, just 1 minus relative risk, so get plus 40%. It means that the relative risk reduction is 40%. This is promising to give you an idea, but still, you want to calculate also the absolute risk reduction. It's also a calculation. It's give us 8%. Then we want to know number, how many patients should I treat to save one? So 1 over the absolute risk reduction give me 13. So are you going to prescribe now aspirin for your patients? You need to treat, for this one, you need to treat 13 patients to save one's life with a total cost of 200 Saudi riyal only per year. For me, I think it's cost effective. Last messages. Absence of evidence, it's not merely absence of benefits. And some drugs got benefited and approval for their adverse reaction, like Viagra. Some other poison, like a rat poison, which became one of the most commonly prescribed drug in the history after aspirin, the warfarin. Gamblers who discovered hypotheses and estimation theories a long time ago, were later introduced and developed by epidemiologists in applied medicine. It's really changed medicine and changed practice and changed even the how to conduct research. I myself owe them all a debt gratitude. That's it for tonight. Thank you for being with me and for listening to me wherever you might be.
Thank you, Dr. Mushabbab. It is a very nice presentation. And it is the basic of the doctor's thinking or way of thinking. Now we learn from the example you gave about using aspirin and how to prevent stroke in a very simple way. You can prevent 8 strokes if you will give aspirin over 100, and this is beneficial. And even if it is less than this, it is still beneficial. But the play of numbers will count. And this is how we use, or as a healthcare professional, use these numbers and the figures to ask the health authority to give more funds for the research and for the medications and like this. You agree with this? Okay. We have some questions for you, Dr. Mushabbab. First question: antibiotic stewardship. We have to follow blindly or observe our area and infection rate and antibiotic response. This is based on the evidence-based practice.
Well, I cannot answer this with doing research, putting the question and go to the Cochrane or PubMed and find the answer.
Okay.
I cannot answer it like this, really.
This is a very tricky question and a very tricky area. Even no one can answer this. But from my side, I have to follow the antibiotic stewardship first. But if there is any resistance, we have to go by our experience. Because as there's a basic slide of Dr. Mushabbab, he said, what is evidence-based medicine? It is theory, doctor experience, and patient preference. Okay? So at the end, you will learn from the theory that you need to do this antibiotic, but there is fear of antibiotic resistance. But from your experience, this patient is in septic shock, and you need to start with a very strong one, not waiting for the culture and overcoming the stewardship. So you can do it. But maybe the patient will refuse, because when you explain the patient, he may refuse these side effects. This is evidence-based medicine we learn from the presentation of Dr. Mushabbab. This is my opinion as an internist. So, second question, if there is good, strong studies, can we follow or wait for the guidelines to develop? For example, SGLT2 inhibitors, I am using since 2016, and just now it is incorporated in the guidelines.
Beautiful. I think guidelines, it's from the randomized controlled trials or from meta-analysis or systematic review. Guidelines, by its name, it's just guidelines. You can improve your guidelines every time when you have new evidence. If you go to the NICE guidelines, the National Institute Clinical Guidelines, the British, the evidence-based guidelines of, and also with the British Medical Journal, they are improving and developing guidelines almost, you can say, daily. But that's why the guidelines will it's give you a safer place to work with, plus also equity between doctors and for the patient. But it's not individualized. Suppose your patient, he has something else that's not included in the guidelines. Go and search and you can update it. I mean, no one can force, there are big difference between protocols and guidelines. Guidelines just guiding you. Even if you jump in between, this is what I know from the British and how they are utilizing and implementing guidelines. They want 80%, 70% of the patients, 80%, 70% of the doctors, they are following those guidelines, or busy doctor, whatever it is. But if your patient needs something else, or he has another question that in your head should be answered, just go and do the search and found it, and you can do it because you have, if you know critical appraisal tools and how to value between those, even some of the, and this is because I want to make it short and because of the time. One of the study, even in this meta-analysis, which is the HBS study, they removed it because actually a lot of ethical issues between the fund. It was from the company itself. So then they removed it after they even did the meta-analysis. This with effect, of course, and while it give actually no clear result. Guidelines, it's not a solid. If you see the hypertension guidelines haven't changed. But one thing, regarding the
which guidelines? European or Canadian
why
or American?
why not to have our own?
Yes, there is.
Yeah, خلاص.
We have.
Yeah.
We have so.
Yeah, خلاص. We have even if you know from each other. Actually, in Saudi Arabia, we are practicing the Western medicine actually. So almost it's the same. Our articles, our everything, it's from them, and we studied with them. I mean, it is not that big changes. Maybe sometimes we could change whatever of the guidelines regarding the antibiotic. The question there, because I'm a family doctor, I'm not an experience with inpatient or with those who are in intensive care. But one thing that I want to add is no new antibiotic since about 35 years. Nothing, no more antibiotic. That's why we should limit the resistance. I remember in the UK, and they said that even the doctor just prescribing antibiotic. They were telling the patient, see, if you use antibiotic, it will be cured within 7 days, and without antibiotic, it will be cured with 1 week. Regarding this, also there are a lot of studies regarding antibiotics. How much it now with like the patient that you have mentioned, it is your patient, for example, in the ICU, and you want to save him to save his life. You will not go and search. Of course, you will use whatever you can, just empirically. That's somebody
Exactly.
like okay, that's it. Thank you.
Okay, thank you. This was the last question, and now we will have a presentation. Updates, up-to-date cancer, colon cancer management, and management of colorectal tumors. Thanks, Dr. Nasser, for
thank you for giving me this chance. I am Dr. Mohammed Nasser, consultant gastroenterologist in King Abdulaziz Medical City, National Guard. Thank you for the organizing committee to give me this chance to present article or subject. I think it is relevant for all the people, and it's very important. We face it day by day in our daily practice. The U.S. Multi-Society Task Force has developed recommendation to guide healthcare provider with surveillance of patient after colon rectal with curative intent. This document is based on this comment is based on critical review of literature regarding the role of colonoscopy, flexible sigmoidoscopy, endoscopic ultrasound, fecal testing, and CT colonography in this setting. The document addresses the effect of surveillance with focus in colonoscopy on patient survival after colorectal resection. Specific consideration for detection of the local recurrence in the case of colorectal cancer, as well the place of CT colonography and fecal test in post colorectal tumor surveillance. In the United States, colorectal tumor is the second leading cause of cancer death for men and women. Combined of estimated 132,000 new cases expected to be diagnosed in 2015. 70 to 80% will undergo surgical resection with curative intent, and up to 40% with local regional disease will develop recurrent cancer, of which 90% will occur within 5 years. The post-operative surveillance of patients with treated for colon cancer is intended to prolong survival by diagnosing recurrent and metachronous cancer at a curable stage, and to prevent metachronous cancer by detecting and removal of precancerous polyps. Surveillance strategy employ a combination of modality, including history and physical examination, carcinoembryonic antigen, CT tomography, and endoscopic ultrasound and CT colonoscopy. Although the optimal surveillance strategy is still not yet clearly defined, the role of colonoscopy is primary to clear colon of synchronous cancer and polyp and prevent metachronous neoplasm. The updated document focused on the role of colonoscopy in patients after colon tumor resection. A comprehensive literature review updated from 2006 recommendation concentrated on the possible adjunctive role of fecal testing and the use of carcinoembryonic antigen, CT scan of the liver and the chest are beyond the scope of this review. The goal of this consensus is to provide critical review of the literature and recommendation regarding the role of colonoscopy, flexible microscopy, EOS, fecal testing, and CT in surveillance after surgical resection of colorectal tumor. Methodology review paper, meta-analysis, gastroenterology textbook, and editorials were searched manually for additional references. The review includes studies published since 2005. Evidence-based recommendations are provided with supporting discussion to guide clinicians in the management of this patient. The review focused on the use of colonoscopy after surgery with TNM, stage 1 to stage 3, or Duke classification A to C, and selected patients with resected stage at 4-stage cancer. When available, it was included the study with the specific reporting of overall cancer, specific survival and rates of secondary, primary metachronous cancer and anastomotic recurrences. Metachronous cancer referred to colorectal tumor diagnosed as secondary primary after surgical resection. And where operating clearing and anatomic recurrence includes colorectal tumor with which core intralumen at or with the close proximity of the surgical anastomosis. Rectal cancer is generally associated with higher risk of local cancer than cancer in other segments of the colon and require additional consideration for surveillance. A high-quality colonoscopy assumes completion of the procedure, cecum or anastomosis is reached, adequate bowel preparation, and meticulous examination by trained operator who meet the adenoma detection by putting mark that can facilitate seeing the lesion. I mean the frequency of conventional adenoma detection more than 25% in average risk screening colonoscopy. The U.S. multi-site task force include gastroenterology experts with a specific interest in the colorectal tumors. These members represent American College of Gastroenterology Association, American Gastroenterological Association, American Society for Gastrointestinal Endoscopy. The USMT task force grade the quality of the evidence and the strength information using as adaptation of grading, the recommendation assessment, development and evaluation grade approach. The grade process involves collection of literature analysis, summary of meta-analysis, and separate review of the quality evidence and the strength of the recommendation. Strong recommendation mean that the most informed patient would choose the recommendation management, and the clinician can structure their interaction with the patient accordingly. Weak recommendation mean that the patient choice will vary according to their value and preference, and clinician must ensure that the patient care is keeping with their values of preference week. Weak recommendation suggests, strong recommendation recommend. Observation study utilizing large administrative database and meta-analysis of random controlled trials showed that patients who receive surveillance colonoscopy after colonoscopy resections have lower overall but not disease specificity mortality. Cancer specific mortality is considered the most important outcome in cancer trials. Possible explanation for discrepancy between all cause and colorectal tumor mortality are unmeasured comorbidity, leading the physician to select healthier patient for colonoscopy surveillance. Cancer survivor tending to be more closely scrutinized and receiving more non-oncologic medical care and inaccurate adjunction of case of the cause of the death. The modality used for surveillance include combination of medical examination and the carcinoembryonic antigen tumor, radiological imaging, and colonoscopy. There have been important improvement in the surgical techniques such as total mesorectal excision for the rectal cancer, CT imaging technology to detect recurrence earlier, and the use of chemotherapy for stage 3 and certain also stage 1, 2, and downstage the patient with possible unresectable disease. Despite this limitation, meta-analysis systemic review incorporating evidence from randomized controlled trial have been conducted. Korean review showed that undergoing intensive follow-up variability defined between study had reduced the all cause of 5 years mortality. It was found that colonoscopy versus non-colonoscopy was associated with improved overall survival. However, the frequency of colonoscopy had no significance on the survival. The most recent meta-analysis, including randomized controlled trial and reported the patients undergoing intensive follow-up and reduced overall mortality, high probability of detection of asymptomatic recurrence. Curative surgery attempted at recurrences and shorter time to detecting recurrences. It is important to note that although intensive multi-modality surveillance is associated with increased overall survival and earlier detection of cancer recurrence, these benefits are most apparent in study using frequent carcinoembryonic measurement to detect recurrent disease. The performance of radiology imaging such as CT to liver metastasis has been associated with improved overall mortality when compared with no imaging in most but not all analyses. The recently published FAC follow-up after colorectal surgery reported that intensive imaging with CT scan of the chest, abdomen, pelvis, carcinoembryonic antigen measurement were each associated with increase of surgical resection and of recurrences with curative intent, but not improved cervical compared with minimal follow-up. The rate of intraluminal or anatomic recurrence are low, particularly for cancer proximal to the rectum, and usually associated with extraluminal that is not amenable to curative surgical resection. The increased intensity of surveillance colonoscopy after curative resection of colorectal cancer does not produce better outcome and might increase harm to the patient. In summary, the evidence showed that although post-operative colonoscopy is associated with improved overall survival, there is no effect on the cancer-specific death and no survival benefit associated with frequent performance of surveillance colonoscopy. The role of post-operative colonoscopy is confined primarily to pre-operative clearing and the prevention of metacoronous cancer lesion. The critical importance of complete high-quality colonoscopy to exclude synchronous tumor and resect polyps in patients with colorectal cancer cannot be overemphasized. In patients with colorectal tumor, the prevalence of synchronous cancer range from 0.7 to 7%. Colonoscopy is preferably performed pre-operatively. However, it can be deferred for 3 to 6 months post-operatively if the colonoscopy is incomplete due to malignant obstruction. The 3-month lower limit is intended to provide patients with sufficient time for post-operative recovery. Intraoperative colonoscopy has been proposed as an alternative approach, although not commonly practiced. Finding and resecting the synchronous precancerous polyps in patients with colorectal tumor to prevent metachronous neoplasia is highly relevant. Considerable evidence indicate that the significant neoplastic can be missed during colonoscopy. The quality of baseline examination measured by the adenoma detection rate is directly associated with risk of development and death from interval colorectal cancer. In fact, the great majority of interval cancer are attributed to missed lesion or incomplete polyp resection. Choosing colonoscopy instead of CT sonography for the first post-operative examination is prudent because synchronous diminutive and flat neoplastic lesion which might be missed or not reported by CT sonography and potentially high relevant in patients with colorectal tumor. In patients with serrated bulbosis syndrome has usually been recognized at colonoscopy that diagnose colorectal or during surveillance after colorectal tumor resection. We recommend that patients with colorectal tumor undergo high quality pre-operative clearing with colonoscopy. The procedure should be performed pre-operatively or within 3 or 6 month interval after surgery in case of obstructing colorectal tumor. The goal of pre-operative colonoscopy are the detection of synchronous lesion and detection of complete resection of pre-cancerous polyp, strong recommendation in your quality evidence. It was found that approximately 20% of metachronous cancer are asymptomatic. The cumulative indices of metachronous cancer of colon and rectum is estimated to be 0.3% to 0.35% per year, presenting at any time, even decades after the index malignancy. Some studies suggested that among older survivors, the risk remained elevated only in proximal colon. Several studies report an increased incidence of cancer diagnosed within the first year after surgery, despite seeming adequate pre-operative colonoscopy clearance. The USMT task force recently recommended that all colon tumor or all colorectal tumors be studied for evidence of Lynch syndrome. The rates of metachronous diagnosed within 3 years was about 30%. The factor involved, or the factors. A review of subgroup of 155 colorectal tumor patients in cancer registry with both complete pre-operative and at least one complete post-operative colonoscopy revealed no metachronous tumor cases. However, there was 3 anatomistic recurrence and 24 patients with 28 edematous polyp, 5 of which were more than 1 centimeter. In randomized clinical trial published by et al. 509 metachronous cancer were diagnosed within 3 years after surgery. It is recommended to perform colonoscopy 1 year after surgical resection of colorectal tumors. The timing of subsequent surveillance is supported by weak evidence and is based largely on the approach to post-operative polypectomy surveillance of patients with high risk adenoma. If the 1 year examination reveals no neoplasia should be performed after 3 to 3 years. And if the examination showed no, then can be 5 years, I mean 9 years from the first time. We recommend that patients who undergo acute resection of either colon or rectum receive first cervical colonoscopy 1 year after surgery or 1 after the clearing of the perioperative colonoscopy. Strong recommendation, we recommend that after the year colonoscopy, the interval to the next colonoscopy should be 3 years and 5 years after that. Subsequently, colonoscopy should occur at 5 years interval until the benefit of continued surveillance is outweighed by diminishing life expectancy. An important distinction is made between colon and rectal of cancer because of the latter has propensity for local recurrence. In the studies compiled for this review that reported on colon and rectal cancer separately, more than 80% anatomic recurrence involved in patients with cancer of rectum and distal colon. Recurrent cancer diagnosed in the colon had high receptivity than rectal malignancy. The local recurrence rate of rectal cancer depends on the accurate pre-operative staging, neoadjuvant chemo radiation for local advanced disease and surgical technique. Rectal cancer recurrence is decreased by total mesorectal resection, in which the rectum and the mesorectal fascia are dissected and blocked by precise, sharp dissection. Excision of the rectum and mesorectum via a low anterior abdominal perineal approach has historically been the preferred surgical approach to low rectal cancer. There is no control trial evaluating whether endoscopic ultrasound improve the survival of patients with rectal cancer. Require multidisciplinary collaboration between gastroenterology, colorectal surgery, and oncology. Recommendation with كيف اروح هذه؟ خلاص مش ضروري. هذه recommendation. Patient with localized rectal cancer who have undergone surgery without total resection, without total mesoresection, those who have undergone transanal local excision, transanal excision, or transanal endoscopic submucosal dissection, and those with locally advanced rectal cancer who did not receive neoadjuvant chemotherapy. And then surgery using total mesorectal techniques are the increased risk of local recurrence. In those situations, suggest that local surveillance with flexible sigmoidoscopy or EOS every 3 months for at least 2 to 3 years after surgery. These surveillance measures are in addition to recommended colonoscopy surveillance for metachronous neoplasia. Weak recommendation: CT tomography is used for colorectal screening and is involving the colorectal in an appropriate option in patients with obstructing colorectal tumor in whom preoperative endoscopy to examine is not feasible. One large case series include 284 patients with obstructing colorectal tumor and reported sensitivity of 88.6 and negative predicted 97.4 for synchronous advanced neoplasia, including advanced adenoma and cancer, proximal to the US of CT review with intravenous contrast has increased, considered preoperative to exclude both synchronous neoplasia and distant metastasis, although the caution is advised in patient advised in assess to complete chronic obstruction due to increased proliferation risk associated with gas insufflation. A large multi-center UK study recommend randomized 3,800 patients with symptom suggestive colorectal tumor to barium enema or CT chronography. The detection of colorectal tumor or large polyps was significantly higher in CT group. However, barium 74 patients without clinical or laboratory evidence of recurrence underwent contrast CT after curative intent for colorectal tumor surgery, and one anatomical recurrence were found by CT scan with sensitivity of 100% for cancer and 81% for advanced neoplasia, using colonoscopy with pathological confirmation as the referred. CT require expertise to evaluate post-operative findings such as inflammatory change at the anastomosis area from true recurrence of colorectal tumor. Diminutive polyps have been extremely low prevalence of advanced histology in average risk patients. There is no longitudinal study examining the consequences of missing or non-repeating of diminutive flat lesion and non-adenomatous lesion in patients with colorectal tumor. In conclusion, although CT tumor has good diagnostic accuracy for cancer, the optimal timing of colorectal chronography has good diagnostic accuracy for cancer in both colorectal surveillance, and how it is best used in conjunction with other modality remain undefined. In patients with obstructive, recommend CT as the best alternative to exclude synchronous neoplasm. Double contrast barrier minima is an acceptable alternative for CT if it is not CT is not available in this area. The local recurrence and distal metastasis in the large cohort in patients who have undergone colorectal resection require expertise to differentiate normal post-operative findings such as inflammatory change and the response from true recurrences. CT scan has relatively low sensitivity for detection of flat and diminutive polyps. In patients with obstructive cancer including the colonoscopy combination, we recommend CT as the best alternative to exclude synchronous lesion. Strong recommendation, moderate quality evidence that test of the are inferior to fecal immunohistochemical test. This is a occult blood test. Recommendation, organization, program, and rapid coverage. Thank you very much for giving me the opportunity to present this lecture.
Just one question, Dr. Muhammad. What is the best guidelines you depend on it for making this presentation? This is a question.
Now, the best thing is that we follow the American guidelines, the Gastroenterology Association for the colorectal tumor. And usually, if you have found one tumor at one stage, you should do after resection. You should do one after 1 year, then after 3 years, then after 5 years.
So it is the American.
Yes.
American. Yes. So the answer for the question is the American guidelines. Okay, thank you, Dr. Muhammad. And now this is the end of our you will receive an email for assessment, and in this email you will find a link where you will have certificate of attendance, and you will be granted for the 21 CME hours. Because I am receiving many questions about people who didn't receive the emails. Please send your email again to Mr. Tamer Ahmed on his WhatsApp number. Okay, for anything related to CME hours or certificate of attendance, Mr. Tamer. Okay, thank you.